So good evening.
Good evening.
Hello. Good afternoon.
Hello, good afternoon.
Hi. I'm Dr. Indian from Vellore.
Welcome, sir.
Just to make sure I'm audible. That's all.
Yeah, quite well audible.
Oh, okay. Thank you.
Okay, thank you. Venkatachalam, sir.
Yes, Roshan.
Yeah. யாரெல்லாம் ஜாயின் பண்ணிருக்காங்க சார்?
உங்களுக்கு தெரியுமே அந்த இதெல்லாம் ருத்ரா ஆச்சாரியா ஸ்ரீஜெயம் என் சமரசம் பிரபால் நகி
ஓகே பிரபல் நகி ஓகே சார்
வர்கீஸ் ஜாயின் பண்ணியிருக்கிறாரு.
ஓகே சார். இவர் நெதர்லாண்ட்ஸ் இந்த கியூஸ்டா ஜாயின் பண்ணாரா சார்?
இன்னும் இல்லை.
இல்லையா? ஓகே சரி சார்.
Hi, can you hear me? Hi, is everybody
Yes,
there?
sir.
I can
Most
only
of us are there, sir.
Is there a, how do we see everybody? Like, is it possible? Or I can just see myself and the screen I can see.
Okay. No, everybody can be seen later on. There will be a side channel where all the
When we go live, you can see just like this. So we are offline. When we go live, you can see everybody.
Yeah, of course. Yeah, you can see.
Yeah, like this.
Hello. Good afternoon.
Okay.
Good afternoon. So the moderators can be seen, sir. The delegates cannot be seen. They are on a different platform. But their questions will come on the side panel. You can see where the audience will send the questions. We need to put it up to the operating surgeon. Or we can discuss among ourselves as well.
Yeah.
Sharp 3 will go live, sir. Before that, once we start the program, we'll have a small introductory session where I'll give the introduction, and then the president of Amasi will welcome the gathering, and then I'll introduce all the faculty, and then we go live with the Professor Palnivelu. Venkatachalam, sir.
Good morning, sir.
Good morning, Professor Christo.
Thank you. Thank you
Yeah.
very much.
Yeah, nice to have you on this program.
Yeah.
Yeah,
You
we
can
have
start.
we have a distinguished panel of experts here.
Yeah,
So
thank you.
down along the program, I'll introduce all of them to you. So
Thank you very
most of
much.
them maybe you're aware of or you know them personally.
Yes,
But
I think so.
since
Yeah.
it's customary, so I have to do that honors. Okay.
Thank you very much.
Thank you, Professor.
Hello.
Hi. Good morning.
Good morning,
Hello.
Professor. Yeah.
Hi.
Good morning,
Yeah.
Dr. Cuesta.
Yeah, thank you very much. Good morning. Here
Good
from
morning, everybody.
from Europe. Yeah.
Welcome, everybody.
Yeah. Thank you very much
Uh,
to
what
everybody.
the what is the latest information I got from the operating room is that sir is getting ready. So it will take another 2 or 3 minutes, maybe 2 minutes past 3 p.m. Indian time. So meanwhile, if you want to have some discussions, you can have offline. So let us go ahead.
Yeah, welcome to all. Welcome, Dr. Prabal, Dr. Srijay, Dr. Kusa.
This is Miguel Cuesta from Europe. You know, so I am working in Amsterdam, but also in Madrid, Spain. Yeah, in the two countries.
Good.
Good morning.
Good morning.
It is a huge honor, you know, to be in this panel with all of you.
No, it is our greatest pleasure to have you because you see, esophageal surgery has been not everybody's cup of tea. So it is with very selected people. And Professor Cuesta is known for doing single organ surgery, that is esophagus. And he has been traveling to India maybe more than 10 years. I have seen him operating more than 5 times. And at Pune, actually, I was in the theater with him. So fantastic surgeon, human being. At Max in Delhi also, we had a live workshop where he operated one of the most difficult, where it was very much adherent to trachea, mid-thoracic esophagus. So I think everybody knows you. So I think today with this esteemed panel, you can definitely throw good light of your experience and share with all of us.
Thank
I'm
you very
Dr.
much.
Rudracharya, by the way, Honorary Secretary, Indian Association of Surgical Oncology.
Yeah,
I fully concur with the words given by our Secretary, Dr. Rudra Acharya, and the esophageal surgery, as he said, is not the cup of tea for everybody. It requires a very great expertise and then a lot of training and other things. Especially the minimal invasive requires still more training and expertise in that field. As he said, I hope this panel will throw light to the expertise demonstration by the Professor Palnivelu. I am Mohan Prasad from Madurai, India.
Thank you.
Welcome, sir.
very good afternoon to everyone. I'm Dr. Inian from Vellore. So it's indeed an honor to be with such a distinguished panel. So we hope to have a good discussion on this topic. Thank you.
Very good afternoon to you all, and my name is Sri Jain. I am from Calicut, India, and I work in the local medical college, government medical college in Calicut. And I've been operating on esophagus for the last 25 years. And my main area of work is esophagus and stomach, but I operate as it's a medical school, I operate other cases also. Thank you. I'm very honored to be in the distinguished panel. Thank you very much.
So your mic is off, Prabal, sir.
I'm Prabal. Of Surgeons of India. General surgeon and laparoscopic work. But my with cancer surgery was before joining the medical college. I was in the regional cancer center as a surgeon, working there for this. My field is more open. I do many more things apart from cancer work. It's an honor to be here with this panel, and Professor D'Costa must be in the morning there, and I can see Dr. Srijay, and I can see Dr. Varghese, Dr. Prashad, and Somin, and Rudra, and all stalwarts in their field. I'm so happy to be here with you guys. Dr. Shetty is there, of course. He's the secretary, I think, of Amasi, if I'm not mistaken.
So we'll go live on a count of 3. Sir is ready, he's washed up, and meanwhile we'll just finish the little part of the introductory part. So Venkatachalam sir, can we go live?
Can go live.
Okay, 3, 2, 1. Good afternoon, everyone. Delegates from India, it's afternoon, and for people in the West, it is morning. So welcome you all for the 8th edition of Amasi Lens program, which is a very successful and informative program that's happening. It's a brainchild of our founder president, Dr. Palnivelu, and also Dr. CJ Varghese, who has made it possible. And for the last 8 months, we've been having continuously, without missing a single month, a spectrum of surgeries being demonstrated. I welcome you all for this program. Before I give the introduction to the expert panel, I request our President, Dr. CJ Varghese, to give the welcome address. Over to you, sir.
Thank you, Dr. Roshan. And once again, Amasi is back with the Amasi Lens program. It is happening on every Thursday of the month between 3 p.m. to 8 p.m. Indian time. And today we are going to have a demonstration on the esophagus, the surgery being done by the master himself, Palnivelu sir, who has popularized his own technique all over the world. And we have an expert panel with us today who will be moderating the session. So both the surgery as well as the discussion is going to be excellent, and it will be eagerly waiting for this wonderful surgery that is going to happen now. And once again, I welcome you all and all to watching for the further proceedings.
Thank you, sir. First and foremost, it's our prime duty to introduce distinguished panel here. I have Professor Miguel Costa. Professor is emeritus professor at Virgin University Medical Center at Amsterdam, Netherlands. He has been a professor and chief of gastrointestinal and minimal invasive surgery since 2001, that is 2001. He works with the Reiner de Graaf Hospital in Delft, Netherlands, exclusively dedicated to upper GI surgery. His research focuses on implementation of digestive oncology diseases in minimal invasive surgery, with special dedication to upper GI oncology. He has been the principal investigator for more than 10 funded controlled randomized trials, and he has, to his credit, more than 340 publications, lots of textbooks he has authored, and it's indeed a proud privilege for us to have teacher of teachers, Professor Miguel Costa. Welcome you, sir, for this program. And secondly, we have our Association of Surgeons of India President, Professor Prabal Niyogi. I welcome you, sir. He has got special interest in oncosurgery, especially the foregut and so on. We are indeed Thank you very much. Next, we have Dr. Rudra Acharya. He's a director and head surgical oncology at Delhi. He's a pioneer in laparoscopic and robotic esophageal surgeries and present the section of long. We also are waiting for another faculty to join us shortly. Dr. Jagdishwar Gaud, who is the South Zone RC president, and he's also a well-known robotic oncosurgeon from Hyderabad. Next is my good old friend, Dr. Srijayan from Calicut. He's a professor of surgery at the Government Medical College, Calicut, and he has got a vast experience of operating on esophagus for last 25 years. Welcome you. And we also have and last but not the least, we have Professor Inian Samarasan. He is a professor of surgery at CMC Vellore. He has got special interest in foregut surgeries, especially oncosurgeries. Welcome you, sir. So, and now I hand over the mic to Professor Palnivelu, who's ready in the operating room. I think one of the residents.
Dr. Roshan,
Yes, sir.
your voice is dropping.
Okay. Am I audible now?
Yeah, very much.
Yeah. I would also like to, at this moment, mention a special thanks to Merrill, who been our supporter for the last couple of Amasi Lens programs, and they have promised to be with us for the next full year. Thank you, Merrill. And now over to Professor Palnivelu.
Hello. Hello. Hello.
Yes, sir.
Yes, sir, you are audible.
Professor, is audible? Everything is okay?
Yeah,
Yes, sir.
Yeah. Good afternoon, friends, and very happy that we are taking part in Amasi Lens program. Today we are going to have a bronchoscopic esophageectomy, and I will ask our colleague to present the patient, then we will start. And I think this is one of the very important fields. Minimally invasive has taken a very leap and bound. Both laparoscopic and robotic surgery today is very much relevant, and the cancer, which is supposed to be dangerous, with a higher complication rate mortality, now today it is like any other surgery, it has been done well. But anyways, today we have experts, and I'm very happy that our experts are joined for today's moderation. I think all of you, your experience today more important to share with our students. So during this surgery, we'll be talking about to last to present the case, then we'll start it. And the patient has been in draped position. I will ask possibly to show the position how they did. You prone, everybody talk, prone, yes, it makes a semi-prone. And the start with those days we do a prone. Now we completely change this semi-prone. So the semi-prone is a position, whatever we talk, prone or whatever this will be. Now I think we can take the patient and
presenting case of 72-year-old gentleman who had presented with complaints of difficult progressive dysphagia for 8 months. On evaluation with the upper GI endoscopy was done. Growth was noted at 28 centimeters from Winchester. The biopsy turned out to be a moderately differentiated squamous cell carcinoma. And after we had a tumor board discussion, we were planned for neoadjuvant concurrent chemo radiotherapy. And then patient was, after completion of chemo radiotherapy, patient got evaluated with the PET scan after 3 months duration, which showed some residual disease. After tumor board discussion, patient was taken for radical surgery. So this is a CT scan picture. And now diagnosis moderate differentiated squamous cell carcinoma. Now plan for thoracoscopic McEwen's esophageal. Now go to Dr. Collier.
May, may I have a question?
Yes, please.
Dr. Shetty, may I have a
Yes, sir.
question?
You can go ahead, sir.
How much radiotherapy was given to this patient?
Could somebody in GEM answer that?
I show the patient before dating, how it looks like that on the chart. Now we can appreciate, and it is about 30 to 40 degrees that we made a patient take. When our table is rotatable, we can rotate to lateral or rotate to pro. Either way, the table can be adjusted according to the face off. Usually in lower abdomen, we always say people a pro. When we go for left lateral angina and right lateral angina clearance, then we go for a lateral approach. That is the way that dual approach can be done the same. Here we have used a single lung and a double lung ventilation, and we have used a single endothelial tube. And the patient position changing everything like any other surgery can do it, there is no problem. And we can appreciate here. This is the laparoscopic view, and this is a scapula. You can appreciate this. This is the angle of the scapula. It should be visible. It is like a swimming position. The hand you can appreciate, the right hand right there, and the patient's abdomen is very full. You can appreciate because margin here. Now this is a 12, this is a 12, this is a 5, this is a 5. 3, 5, 7, 9 like it. Generally we keep it displayed. Initially promo alone we used to keep a program here. Now we go to immediately because when we are going to working in camera will be there, this is working profile, this also working, so that we can look here. When we work above and shift the camera to this, and these two become the working profile, then clearance of the right cervical, right clearance and current tracking side will become more easier, and we'll take the table accordingly. So then I'm starting it, I'm going to make it a first program for a camera. I'm going to use the Excel program. Excel program is got a transparent shot. Now you can appreciate here. And this is way when the camera goes inside and it will be visible. So when you go, because of the shape, we can see the tissues and we can appreciate it. So I make a incision and the quick.
So first trocar is a blind trocar always, but when you put with the VG port, you can just see the lung definitely, and you are just in the space.
Always gas must be flowing. See, the sister has forgotten to do it. As it goes, the lung will collapse. Now only we initiated the flow. That's why the issue it is. Standard நீங்க சொல்லி வச்சு பண்ணணும். Now we can use a 0, I can change it to 30 if I want. Now we can appreciate, and the pressure I kept it 10 millimeter mercury, and we can appreciate lung slowly collapse. The anesthetist knows how to bring down the tidal volume so that lung collapse will much more. Now bring it down. Sharpen the camera. Okay, tilt the table to my side, into prone side more. Now this is the apex. And the vertebra you can appreciate, intercostal, this is downwards. I think I will change the 30 degree. How much? Could change 30? And another way I used to do it, all would have seen many of this. I used to Virasnid itself, and but safer is using Excel trocar, and Visiport technique is the best way to do. Even lung addition there will be known, and if no lung addition, Virasnid is safer. But in Indian setup, some small percentage, there may be addition between the lung and the parietal pleura, and the needle may go into the parenchyma. It happened a couple of times, and then we changed completely to Excel prone Visiport technique. என்ன நீ தட்டு மாதிரி இருக்க? ஒயிட் பேலன்ஸ் பார்த்துட்டீங்களா? இன்னொரு தடவை ஒயிட் பேலன்ஸ் போட்டுருமா? ஓகே, saline. You can appreciate azygous venous arch is now it is visible. Superior mediastinum, lower, and the diaphragm. And because of pneumothorax, diaphragm also will push down. That claustrophrenic angle also will be wider. Now I am going to make it another 12 mm trocar. Koduma trocar kodu. Trocar belluma. Ninga idukella vandu. I'll be happy somebody initiate some talk, no?
Yeah, previously we were using double lumen tube. Now mostly single lumen tube is used because of the prone position. That is the advantage, and it can be done. In fact, in any kind of setup, you need not need a good anesthesiologist who can do a double lumen intubation. So that is the beauty. And the other point is everything is upside down. So it is the surgeons who are doing this type of esophageal surgery. They are mentally, anatomically oriented to prone position orientation. And best part is whatever you operate, whatever blood trickles, that goes below by gravity. So it does not come on the way of the surgery. That is the biggest advantage in prone position esophagectomy.
And in addition to that, the lung also falls down.
Yeah,
So it
correct.
is out of the way. So you really don't have to retract the lung, and it falls out of the way. So that is the added advantage.
Professor
Professor,
Cuesta,
Hello?
Yeah,
Professor Costa had one question, sir, for you.
Yeah.
Sir. Yeah.
yeah,
Professor, you can go ahead.
yeah. Professor Planivelu, thank you very much for this invitation. And usually our patients here in Europe are a little different because they are thicker, they are more obese, etc., etc. But
Five,
we put the
seven.
patient in the same position as you do, and but the position of the trocars is different because we try to put all the trocars between the spine and the scapula. Can you comment on this? What is the best position according to you?
Okay.
Why do you put the trocars in this?
രണ്ട് bowel forceps. Now you can appreciate the trocar's position. Huh?
Yeah.
This
yes,
is
sir.
2,
Yes.
and this is usually 10, okay.
Yeah.
But you always sometimes stapler we want to use, we need a 12. That is the reason I'm just to make it straight away. And because we have another patient, I had done abdomen already. It is Ivor Lewis, waiting for next one. I'll show this. Then this is for 3-stage neck anastomosis. That's going to be intrathoracic anastomosis. Almost done. That patient also ready. After this, I'll be going. Curved one. So that way, my mind just took it all 12, full placing it.
Yeah, sir, Dr. This is Rudra here, Dr.
Yeah.
Palanivallu.
Yeah,
So, Costa sir is asking, our port positions are lateral, like we put like Japanese, and his port positions are mostly between the spine and the like more vertical,
Yeah.
more towards the dorsal aspect.
Yeah.
But if I answer, we go the Japanese way. Even lateral, we have found that reaching above and reaching vertically up, because sometimes we operate patients who are little old age. The spine is quite prominent. So when we do from a little lateral, we can go up, and our camera can get directed bypassing the spine
Yeah.
to the esophageal space.
Oh.
But when we go more posterior trocars, what we have seen is the anterior dissection is easier, but the posterior dissection is little cumbersome.
Okay.
So this is our technique. I follow
Yeah.
exactly SIR's technique,
Okay.
both in laparoscopy, thoracoscopy, and also in robotic. I use the same ports in both.
Yeah. Here I'm going to start the steps I'm going to tell now. Anterior dissection I'm going to do first, and crossing the esophagus arch, controlling esophagus, I'll be towards this. I'll be going for a right laryngeal. Now this anterior dissection I'll finish first. Then I'll putting a tape to lift up this esophagus. So then finally I'll be going posterior dissection. Initially I was doing both together. Then Japanese article one came, and if you do sometimes together, that may be a blood trickling from down, that may spoil. So better to doing it than anchoring the tacking suture the esophagus we do, and we have a more retraction inside, no need for assistance. Now this is a tumor. You can appreciate tumor starts from here by endoscopic and goes down almost 6-7 centimeters continuously. This patient, because initially chemo radiation given, but because longer gap, very happy that not much of a reaction there. And I'm taking gas piece, keeping it inside.
What is your usual duration?
Pardon?
Usual duration post radiotherapy?
Huh?
Duration, how long?
It is already 5 months over.
Yeah. So 5 months is.
Why happened? No, that patient is thought after chemo radiation they did endoscope.
Everything is okay.
They found out total tumor disappeared, and they thought it is a cure, and they did not go consult anybody. They were delaying it, and by the time then they developed a pain, then they consulted back again the recurrence at the same primary tumor.
Dr. Palnivalu, this is Mohan Prasad here.
Yeah, Mohan, yeah.
And what was the dosage of radiation given? Do you find any difference in patients operating after radical radiotherapy or a neoadjuvant preoperative radiation?
That's why we don't give radiation if you're planned for surgery.
Yes.
Chemo is better. Radiation is 50% of cases. The plane will not be proper, then it becomes a problem. But if
now,
you think, if you
in the picture, it is see you are getting very nice planes even after a full dose of radiotherapy.
Mohan, you are not seeing the plane exactly. Here it will come. You'll be later looking at now.
So he's just simply doing the plural cut. When
Ah,
it goes enterally, the plane between the membranous trachea
yeah,
and
yeah.
esophagus, that is the real place. Actually,
The
I
left
agree with sir.
bronchus is a concern this particular case.
Yeah,
Okay.
correct.
And my concern is where I reaching it. If it is free, I'm happy.
Yeah.
Okay.
And that way we have to dissect and see whether it is a resectable or not. Sometimes, it may look like imaging wise looks easier, but later it will be known.
Yeah.
Okay.
So, sir, always you use a hook only
That is the
for the
best.
plural cut.
Yeah, that is the best instrument because it is always towards you.
Yeah,
And,
correct.
and
But I do everything with one ligature only. Ligature only from the beginning, first step.
I use ligature, I use cartridge, I depend on all instruments,
Yeah.
depending on the stage.
Because me and Subramanian Rao sir both are pure ligature people.
Oh.
Yeah, we are doing the same procedure as you are doing now, using the hook and
You
in
can
the
appreciate
most common
here.
cases, we use the radiotherapy, but
Now you can appreciate there is no plane here.
Yeah.
Oh, yeah.
No, but
Sister, in the case ready பண்ணிருங்கம்மா.
you
So when you see that the planes are not good, always go to a virgin place where you can find the planes and above and below, and finally you can have a thrust at the site of Henderson. Dr. Cuesta, you are always happy with the hook. I have seen you operating with the hook only.
I am very happy with the hook, and I am doing the same operation because I start also on the one side and try to find the plane like Professor Planivel is doing now. And I am very happy to see that.
Yeah.
That's a very good plane, to develop.
So, because if you use the proper plane, you will see every structure. You can now see the exact plane between the paraesophageal fossa and the pericardial pericardium is just above the infrapulmonary ligament, and is doing the is taking the periesophageal fossa along with the esophagus, which will include the lymphatics always.
Yeah.
So it is very important to be in the right plane to take the lymphatics along.
பைப்புல தூள் எடுத்து வச்சுங்க.
Well, it's very interesting because you see the different tissues around the tumor, that the pleura was thicker, and the plane perhaps will be not so easily found, I think, because the radiation, the radiotherapy.
Yeah. Because
you see
this is the place you can mark when high dose of radiation is given. There is very high tissue edema. Along with that, the planes are difficult.
I see that now. You see
correct.
the small points everywhere.
So that is why I feel this patient must have got 54 grays, maybe full chemo radiation.
Yeah, I see that. That is very good. That's visible. Yeah.
Otherwise, normally we give 50.4, but when you give definitive, you sometimes give 54 grays. Otherwise 50.4 usually, and some people they modify in the modified protocol they give 45 only. So but our center we give 50.4 for neoadjuvant.
That is for us, this operation is very difficult because the amount of radiation that was given and the time between the radiotherapy and the operation. So that we consider that, and in many countries, like in Japan, they prefer to do the open operation because this radiotherapy.
Correct.
So we
So,
But India is a country where we all believe in chemoradiation. So we operate all patients with the chemoradiation only. And but at the same time, we operate between 8 to 10 weeks. We don't wait so long. But as sir told, Indian patients are so variable in their economic status, everything. They take time to decide for a surgery with so many consultation, and that results in delay, and delay leads to more fibrosis and makes the surgeon's life more difficult.
That is, in our case, is the same. You know, we are doing the same operation. We give 42 grays with the cross skin, and we wait for 8 or 9 weeks for the operation after the finishing the chemoradiotherapy. But I do agree with Professor Pranivelu that in the future will be better to give only chemotherapy, but now still we are doing like you the chemoradiation, according to the cross scheme,
So I have a paper myself published 4 years back, in comparison between chemotherapy only and chemoradiation. It's in the index journal, Indian Journal of Surgical Oncology, and there what we found is even chemotherapy we could get very good response, and we could get good clearance in surgery, and the histopathology was almost similar. But one point of difference was with chemoradiotherapy, we found more pathological complete response, what is called as PCR. The PCR rates were high when we used chemoradiation. So,
I do
but
agree with you,
ultimately, when we compared our 86 cases, 43 only chemo, 43 with chemoradiation, 50.4, and ultimately in the analysis we found that the histopathology, the 3 years we had done 3 years follow up, and the 3 years follow up was almost similar. So
I do agree with
gradually
you.
we are
You know.
taking to more chemotherapy like the Japanese, but definitely we give chemoradiation when we find mid thoracic tumors, mostly chemo to lower lower third esophagus, and plus in elderly age where we cannot give both chemoradiation because they will fail in completing the chemoradiation.
Yeah, I do agree with you. I think the survival after 3 years will be the same, but the local control of the tumor will be better by chemotherapy, and this is a very important thing because the tumors, the squamous cell cancer, are sometimes very big, and if you give chemoradiotherapy and you get a very good local control of the tumor, the operation will be easier, I think. So at this moment, there is still controversy. What will be better, the chemotherapy or the chemoradiation? And still, but what you have said that is very important, that the survival at the end is the same, more or less similar between the two methods, the chemotherapy or the chemoradiation. So still we are discussing what will be the better in the future. But still there are important advantages giving chemoradiation. But the problem is if you wait longer than 8 weeks, the fibrosis, locally fibrosis, will be increased very, very importantly, making the operation more difficult. That is the
So
point.
whenever you find such a situation, dense fibrosis, and you feel that the planes are difficult, any tips you can give Dr. Cuesta? Dr. Palanivelu is doing a fantastic job. He's
Yeah.
just avoiding the site of adhesion. Is going from the virgin side and trying to get the plane. But any insights on this type of adhesons? How do you tackle? Any tips from Dr. Cuesta?
Yes, I think Professor Palanivello is doing a beautiful operation, very gentle, very carefully in this point, and that is what I will recommend to everybody. Using the hook very properly, going forwards and very small pieces, trying to, because there is no plane. You can see here there is absolutely no plane. So you have to develop according to your knowledge of the surgical anatomy. And because there is a lot of fibrosis there. And that is
So it is called as imagine the anatomy and develop the plane. And the second thing Professor Cuesta mentioned is to be like you can say chicken bites, very small bites. Go with very small bites with a hook or with a ligature, very small bites, because this is the place very, if you are not very, because you have to be very clearly in the plane of paraesophageal fossa, and if you want to err on the esophageal side, not on the airway side. That is the most important, because the moment you are more posterior, then the chances of getting a membranous trachea, small hole, is very common. But if you are more on the esophageal side, you might just leave a patch of paraesophageal fossa which is already irradiated on the trachea, rather than causing problem to
left
the
pulmonary
airway.
vein. Bronchus.
I do agree with you.
Bronchus
I think the way is what the
Yeah,
Professor Palanivello has done to
Total
open the
pulmonary.
space proximal and distally of the tumor, and in the middle, because the very important fibrosis, to operate with small bites and trying, I think is a very good term, to imagine the surgical anatomy little by little. I think he will find the resection plane in a couple, but you see that the fibrosis here is very, very important.
And another point of tips is never do any blind cut. Like you can do the dissection, but never put the ligature in a cutting mode in a blind place, because on your side you are seeing everything, but the most important area is the other side, opposite bronchus, that is the left bronchus, where you are not able to see anything, you are totally blind. So
Hello?
always do the dissection
Hello?
from your side to the
Hello?
opposite side.
Yes,
Yes, sir. Please, sir.
Here, bronchus is not issue.
Yeah.
This is a left bronchus here, a left one here, right? But
Correct.
here the pulmonary vein is a concern here,
Yeah.
and that is the way now we have to carefully separate. Let us hope so.
It looks very tough, sir. Good afternoon, sir.
Yeah.
Jagdish here. And we are managing
Jagdish,
so nice.
welcome. You're late actually. Sir is in.
No, I was there. I was watching sir's surgery.
Okay.
And
So I
listening
think
to you.
he's at the.
So what I'll do hereafter, I know that left side I'm able to go.
Yeah.
So here it's fine. So what I can then mobilize other areas will go to this area. No? And I have to.
My take at this place is, if you can loop the lower part esophagus and give a traction, you will see the opposite side much easier. Because if you do the uppercut and pull the lower part of esophagus, then opposite side may be better seen actually. But really, sir, commendable job. Very dense fibrosis, and you are moving so nicely, slowly, steadily. It is very commendable actually.
But I think it's very important because what Professor Palaniveru has said, that the bronchus is not the problem in this case, because it is 2 centimeters or 3 centimeters distal, but the problem can be, the pulmonary vein. But that is what we have said, little by little, trying to imagine what is the surgical anatomy, and in this case, we need a lot of experience and skills to doing this operation properly, steadily, but at the same time, very, very carefully. And what I think is, it's a very good, to try to find the posterior plane of the esophagus in this case. Yeah.
Generally, I will go last, but this particular case I want to do, gas suction.
Yeah, sir. Same thing I was suggesting.
Yeah. I think it's a very good suggestion.
Just loop the esophagus, then that.
Suck.
Yeah. Because unless you see the opposite side, you will be always fearing to going blindly actually. Yeah. Jagdish, do you feel such kind of difficult places, robot will help in any way different than this laparoscopy?
No, I don't think so. Sir is at a very critical place, the pulmonary vessels, which whether it is robot or lap or open, we have to be very delicate and very slow,
very
and
true,
steady.
very true.
I don't think it makes a difference.
It makes any difference, correct.
Actually, many times we keep silent when such a place somebody is operating.
Yeah.
So it's so tough it is actually.
No, that is why I am engaging in discussion, keeping
Yeah,
sir
I
silent.
know. I'm just telling, like,
Keeping sir silent actually.
it's such
Let
a
him
tense
concentrate
moment.
on surgery actually.
It's such a tense moment.
Yeah.
No, I do agree, because we are using the robot, more and more.
Yeah.
But if you have to say what is the advantage of the robot in this operation, perhaps it's the view that you will get with the robot, but the handling with the instruments, I think is not superior. Not superior.
How is the picture quality? Is okay, no? From your
sir,
side?
super.
Yeah,
super.
The picture is very good. Yeah.
Very good, sir. Super, almost.
Yeah.
And even I have somebody messaging that even to the delegates, it is very clear. So that is an anterior pleural cut and paraesophageal area. So now sir has completed the anterior pleural cut because he wants to encircle the esophagus to visualize the left side.
One of the points is that what you have said, that in India you use the chemoradiation like we do in Europe in many centers, with the exception of the UK and Ireland. But in Japan, they don't like, the chemoradiation for the minimal invasive esophagectomy. But you have to be experienced, handling with the fibrosis and with the difficult planes. So I think the experience and the skills are very, very important. So that is not one of the first cases, to start with.
Yeah.
I think that is very important.
Never.
To
I think this type of case you should handle after doing minimum 50 cases.
Of course, many cases,
50 cases minimum.
Many cases, but the view that you get with this position and the position of the trocars, I think is superb. It's very good.
Yeah, that is what even I have seen Professor Daiko in NCC operating sitting. Actually, he sits and operates with the same trocars because they're lateral trocars. He says that we do long surgeries, so he sits and operates. So I've seen the same place. I use the same trocars, but like sir, I do standing only. Yeah.
Yeah, that is the same position that we use, for the robot, more or less,
Yeah. For the robot, same actually. Same.
Yeah, the same. That is the banana position, of
Yeah,
the
correct.
trocars. But we put the patient in more semi-prone position, eh?
Section.
We put all patients in semi-prone only, and then we do the. Dr. Cuesta, have you tried before? Not now, because now this is the most popular. Have you ever tried a lateral position? How was the experience? And do you
Yeah.
think you feel that you sometime might go back to lateral position?
No, I think it is a very good question because we started with the lateral position until the paper of Professor Palanivelu.
Yeah.
They was very impressed with his series, and we started, carefully with the prone position, and definitely the prone position is the position to operate the esophageal cancer. The semi-prone is sometimes we give 20 degrees in lateral with the semi-prone. But now what I see with the robot is that the patient is positioned almost in lateral. So it's very, very interesting to see the changes, But if you operate by minimal invasive without the robot, the prone position like here is the best position that you can use. But for the robot, we are using more lateral, almost 70 degrees, something like in lateral position,
Because all the robotic arms have to go in one line and from one side. So definitely that position. So we are also feeling the same, but it is just a orientation. But the only advantage of in such a difficult case to do with laparoscopy is that you have a tactile sensation, whereas when you are doing robotic you don't have the tactile sensation. So how much to give the traction, how much to make the planes, because in such a case if I use my laparoscopy instruments, then I have a additional advantage.
I do agree with you, but in our opinion is the robot is all the advantages at least in Europe is winning and winning.
Anyway, but then difficult case.
But it's but I like this operation, because that is what you say, the tactile feeling, and everybody is here with you. You are near the patient, etc., etc. But that is amazing. That the robot is increasing, the every day, at least in Europe, and I don't want to say in the United States, the robot has been used, for inguinal hernias and other small operations. So we use this at this moment. We do 50% with the robot and 50% doing the thoracoscopy in prone, like here. And my feeling is that the advantages will be perhaps, in difficult cases of the precision that you can have with the robot. But that is the way, like Professor Paranivelu is doing, trying to find with a lot of patients, little by little, trying to see the tumor from behind, front, and at the end, the operation will succeed.
I'll cut
So
the azygous arch, then I will go so that I will have more retraction.
So you are going to take down the
Azygous
vein.
arch, yeah.
Yeah. I think it's a good step now.
Dr. Samarasam?
Yeah. Yes, Dr.
I'm Dr. Jagdish here.
Yes,
So I
Dr.
just want to
Jagdish.
know your take whenever you see like a tethered tumor at the pulmonary vein, at the pulmonary vessels, for the juniors and for the youngsters who start this procedure, what precautions you would say to be taken? Because I think it's the most scary moment, especially with robo. What would yours is a big institute. You must have seen such cases quite often.
Sure. Basically,
One or two steps. Well, sir is engaged. 2-3 points.
Just to go back, basically our protocol is to give the cross regime, which is 40.6 with paclicarbo. For the mid esophageal tumors, obviously we get about 50% complete pathological response with the cross protocol, and like what Palmelo is doing now, basically this kind of tumors are really challenging. One has to be very, very, very careful, like what sir is doing. And at this near the airway and near the pulmonary, the inferior pulmonary vein, etc. Like what we have been discussing, the robot versus the laparoscopic. I think either way it is a challenge, whichever way you do. In fact, maybe it's a little bit better with the laparoscopic. But I think the real advantage with the will be the suprachoroidal dissection, the nerves, etc. But here, either way, one has to be very, very, very careful, go very slowly, like what Professor Costa was also mentioning, go very slowly, get a plane from virgin tissue to normal tissue, and then take it from there. So that could be, the how one has to do, and of course, it's not something that you can take easily.
Like rectum, have you tried follow-up in esophageal cancer post CTRT complete responders?
No,
Like
sir,
any
we haven't.
initiative?
We don't do the wait and watch
Because
policy.
we are getting cases now. Yes, in esophagus. I think rectum we are following some cases, but esophagus, my institute, we don't do that. I want to know from you, sir.
No, sir. We operate on these patients. We don't do the wait and watch. The complete responders, still the complete pathological responders, we still don't have, pre-operative assessment, a complete pre-operative assessment that can tell us a complete response.
Yeah, because recently we did two cases and it did not show any tumor. So the attenders were, was it really needed? No, such type of questions are coming. I think CMC or some institute should take an initiative regarding that.
Sure, but I think I can.
As of now, yeah, we are justified.
Yeah, and we can get the opinion of the other panel members also. But as of now, we don't have an investigation to tell us a complete pathological response.
True.
So, I guess.
Second thing, how much duration do you give, sir, after CTRT? Ideally, I mean, your institute.
Regularly.
Sir, we wait for about 6 weeks to 8 weeks. CRT, that has been our protocol. And after the cross regime.
So there is a question from the audience. The pulmonary vessels are the place where the disease was stuck, where you saw the dip like this, where sir was doing dissection. That's the pulmonary vessels. There's a question from the audience. I'm answering them, sir. And the bronchus is actually a little higher. It will come just below the azygos. I think eventually sir will show. So I hope that has answered your question, whoever has asked.
Yeah, I think it's a very interesting discussion because the total response of the tumors in squamous cell cancer is almost 50%. And when can you wait and watch? That is it was the last discussion about it, and we have performed the SANO trial in the Netherlands, and that is
bipolar கூட
if you get a total
gas fees எங்கம்மா
response,
இருக்கு
a total response,
வேற gas fees கொடுங்க
the outcome of the patient without operation will be very, very similar in relation with the operated patients. But my opinion, a very, very,
bipolar
very careful opinion is that
lens clean பண்ணுமா
because the mortality is so low,
இதை பண்ணிட்டு
and the patient is getting very nervous and very excited every 3 or every 6 months with all the studies again. And sometimes if you get a relapsing of the tumor, the operation is almost impossible, because that is very difficult fibrosis in the tumor. So my personal opinion is that you have to operate all the patients, but still there is a big discussion with the policy of waiting watch. If you can demonstrate that after chemoradiotherapy the tumor is completely gone. I don't know what you think about it, but I prefer to operate all the patients,
Yeah. One more thing, Professor, is the intensive follow-up that is required every 3 months, 6 months, and the cost of the follow-up. So that may be very difficult in a country like
very
ours.
difficult.
Yeah. So that is again a real problem.
Yeah, I think so. Even in Europe, it's very, and this policy is only for the squamous cell cancer, not for the adenocarcinomas. And can you imagine that in Europe at this moment, adenocarcinomas of the esophagus are almost 80% of all the esophageal cancers, and only 20% are squamous. Can you imagine how the difference are between India and the countries in Europe, where the adenocarcinoma is getting the majority, and that is in almost all cases are located at the level of the carina or distally.
So there's a question from the audience. What will you do if you injure pulmonary vein? I think if you are not as a gold standard, I feel we should try to put a gauze piece there, do a pressure, and then try to open it up. Very, very, very experienced surgeons may try to repair that, but it's very risky. That's why whenever we are operating and when we are dissecting near the pulmonary vein, we always keep 2-3 gauze pieces next to that and use the pressure whenever it's required and be very, very slow. And if we feel that the pulmonary vessel is the sheath is going to be dissected, then we should if experience is not there, we should abandon the procedure. We should not do blindly. Experienced surgeon like Professor Palnivelu sir is not the one to be emulated by everyone. Even sir, you see, so carefully is doing. I don't know what senior Samarasam sir. There's a question from audience. If you injure pulmonary vein,
Yeah, I would agree with you. I mean, basically, you need to be very, very careful. So, if there is an injury, like anything else, don't panic. I think you need to put pressure, probably wait. But in a major vessel, one needs to be very careful. So, inform the anesthetist, etc. So, it's like anything else, but I think you need to be prepared for the worst. I think that's the key to it.
Dr. Jagdish?
Yeah, yes, sir.
Yeah,
There's one more question, sir. Thoracic. Yeah, Roshan. Roshan, please tell me.
Yeah, Dr. Jagdish, Dr. Srijayan here.
Yes, sir.
Yeah, please.
Yeah, preoperatively, if the lesion is at 32 centimeters, we have to be extremely careful about the pulmonary vein. So sit at the console and see what is the status there, what is the association with the pulmonary vein and the lesion. And if it is stuck there, it's better not to operate. That is one. And if we plan to operate and see at the time of surgery, definitely, if I would like to continue with the surgery, I will more dissection more towards the esophagus than the pulmonary vein, because once pulmonary vein is injured, somebody was asking the same question, the bleeding will be profuse and will not be able to manage it probably like pulmonary may be able to manage it thoracoscopically. But as I will be opening the chest and I'll manage only like that. I'll not be venturing into thoracoscopic repair because it's a larger vein and it will bleed profusely. So more towards the esophagus, or even if we keep some part of the tuber, it's all right. That's what I believe.
So if you see
Agree.
the planes SAR is doing is mostly following the paraesophageal fossa. So if you keep the paraesophageal fossa intact and stay in a plane just outside the paraesophageal fossa, when he's doing the anterior, you can see very well that is going between the paraesophageal fossa and the para-aortic fossa. So these fascial planes, if you give proper respect, the chances of injuring the brain is very less. But if it is definitely, as sir told, radiologically, if it is adherent, better not to do the surgery from the beginning. Or if you think that it is a borderline, like less than 90-degree contact, then you can attempt. And sometimes you get a very small lateral tear where you have to take a suture. But as I always do is, it is better to err on the esophageal side, whether it is pulmonary vein or whether it is bronchus or it is membranous trachea. Every time remaining on the paraesophageal fossa, one layer of paraesophageal fossa, like one disc of the fossa, does not make any difference, because in India, most of the patients, what we get is after post chemo radiation, the radiation field has completely sterilized that place. So even if you leave one disc of fossa, it is not going to cause any major site of local recurrence. So it is very important that the fascial planes you should be very much aware of. Now just see this plane where it is dragging the vessel towards the esophagus, and sir is exactly going in the paraesophageal plane and leaving the vessel towards the other side, and he is tethering the fossa but not going towards the vessel. This is the beauty of the a very experienced esophageal surgeon, what he will do when at this point. But definitely,
Yeah.
if you injure, there is no going back. It is a major vessel injury. You have to do a vascular repair by any means.
This if it is not disturbing to sir, I think there is one more question. Whether
Go ahead.
okay, sir. Thoracic duct active searching for thoracic duct and ligation. Actually, my practice is
thoracic jet cutting pakla. No. ICG, show the ICG. I have given ICG injection before.
Yeah.
Let
yes,
us
sir.
see the thoracic duct. But if
Okay,
thoracic
okay.
duct is injured, I don't bother about it. I'll put a clip and come back, but I should
Yeah.
make sure that it is injured. It should be known. That is only thing.
So
Yes, sir.
the
There is
point here
a
is what sir is making is, just before putting the patient in prone position, in the supine position,
Right.
both the inguinal nodes should be ultrasound guided,
Sir?
or both the sides of the inguinal node, you should give the
Vidma?
ICG, so that the moment you start dissecting, if you make
Who
your
put it?
screen ICG mode, you can see the thoracic duct traversing
Amma,
completely.
ICG mode மாத்துங்க.
So the question is number one, whether you will actively search for it and will you ligate it. So the answer is I usually do only robotic. I don't do thoracoscopy. So we always use Firefly and we never search for it. It is seen. Even whether it is, even if you don't use Firefly, I don't go and search for it. I don't go do preventive clipping unless I'm planning a very extensive
lens மாத்தணுமா?
lymphadenectomy. So the answer is we don't search for it. We don't actively look for it. We can use ICG and then be safe around it. Unless you are a believer in en bloc, I think Professor Samarasam can tell his idea.
Yeah, Dr. Jagdish.
Sure.
Yes. Any
Srijan, you go first, Srijan.
okay.
Yeah,
So
Dr.
you
Srijan
just
also.
try to see where he's searching actually. It is
In
just
all,
the paraotic place on
Hello?
tubular
Hello?
structure. Yes, sir.
Here
Yes,
is
sir.
a
Yes, sir.
thoracic duct.
Yeah, correct.
It's a groove we have to look for.
Yeah,
And let me check it ICG.
yeah.
And I give an injection, but it's still more mathupa. Okay, let him check it. Meanwhile, I continue here.
Yeah, please continue, sir. Please continue. We are continuing with the discussion. You can
Yeah,
continue.
this is made a mistake that I that made that injury. I'm helpless. I should come out without injuring the vein. That's the only thing.
Yeah, that's okay, sir.
We can
That's
see,
okay.
sir. It's
Don't worry.
very,
Don't worry.
it's a very
Don't worry,
difficult
because I told
area.
you, even if you leave a disc of tissue, we have seen in the long-term follow-up, it doesn't make any problem. Yeah.
okay, Dr. Jagdish, actually, in all cases, I used to search the thoracic duct that is just below the esophagus vein, that is
No, actually,
between
you
the
search for
esophagus
it, sir.
vein. Yeah,
You
just
search for
below
it.
below the esophagus vein and above the aorta. If we pull the fatty tissues, it will just come out, and we'll be able to easily visualize the thoracic duct. And I used to trace it till
I
the gastroesophageal junction. Because the reason is,
I
if
don't see
injury
light.
occurs and if it leaks, then second surgery
No,
becomes
I
very
don't
difficult.
see.
So in every case, I used to
I don't know.
deliberately identify the thoracic duct till the G junction,
No,
and
no,
from
I
there.
don't see.
That is not
I
only
see the
practice, and
tissue
all the tissues in front of
until
the
the acid
aorta
vein,
also
I
will
think
get
but
damaged.
from there I don't see anything. Not the
Sir, in my
operation part.
practice, I never actively search for it, sir. If it is seen, it's seen. Unless I do envelope 3D, whether it is
Yeah, okay.
robot,
I am going to
microscopy, I
do
never
that.
search for it, sir.
இல்ல சரி உள்ள மாத்திருப்பாங்களா ஜெய்
So,
போச்சா இல்லையான்னு தெரியலப்பா
my take is little different.
Yeah,
Once
yeah.
you complete your procedure completely, just go at the diaphragmatic end of the esophagus, pull the esophagus towards you, and just see that there will
இல்லம்மா
be a
அது
vertical
புரியாது
structure the uh, parallel to the aorta between the paraesophageal fossa and parotid fossa, and I do regular clipping, because I believe 2 clips at that point will keep you completely sleep very nicely in the night.
You
Don't
clip the
have to see
thoracic
the
duct.
I
You
do
clip the
it
thoracic duct.
prophylactically at the lower end only. I don't search it above,
But there's no data
because
about it.
at the entry point it is just no, there is no data, but it is
Yeah.
our practice actually, and after finishing the whole procedure, because at our center also sometimes we give ICG, sometimes we don't do give. So we have not made it a protocol, just like Dr. Subbu sir does in every case. So in our center, end of the procedure, I just look at, if it is visible, I just put 2 clips, metallic clips, that's all, finished.
Okay, Dr. Rudra, it's very easy to identify the thoracic duct just below the crossing of the esophagus vein, and
I know, but
thoracic duct
when it
also.
is entering the thorax,
Yeah.
anywhere you have been injured, if you put the clip at the entry point at the diaphragm, it will take care of everything above. That is how we do it at the lowest mode part.
Yeah, okay. The one problem which I have encountered in the lower part is the amount of fat in that area is high, and the amount of fat just below the arching of the esophagus vein is less, and it is easy to give traction.
Maybe it's
Yeah,
person to person, it might
maybe. Yeah.
vary, but
நம்ம இழுக்க
I will
முடியாது அவங்க
demonstrate it
விட்டுட்டாங்கன்னா
day
நான்
after.
தான் அதை
I have a lab
விட்டுட்டு
group,
வரணும் குரூப்
and
விட்டுட்டு தான் இருக்கும்
I have done it in laparoscopy and thoracoscopy both.
அந்த
I
கேஸே
have the videos.
பண்ணியிருக்கலாம்
I will be
மாட்டேன்
demonstrating day after also.
Okay. So here there is a lot of infiltration and fibrosis, and the tissues
Yeah,
edema.
I think
தள்ளி
this
வைங்க
area
இங்க.
is quite difficult.
முதல்லயே
Sir,
செக் பண்ணி
there is
பார்த்தோம்டா
in this kind of situation, there is another technique, is to divide the esophagus with a stapler. And when you divide the esophagus, the stapler, and just hold the catch hold of the blind end, you can see the other side very easily. That is another technique.
What I think another possibility is to take down, a piece of pericard sac. I don't know what you think about it.
Medical?
Pericard sac. The
Pericardium.
yeah, pericardial. Because
Okay.
sometimes what we do is open, you know, a little bit the pericard, the pericardial sinus, and from
Yeah.
there we see what is the
Yeah,
extent.
but you see, this place is stony hard actually, almost.
No,
So
no,
that
It's
is
not
where it's finding the problem.
pulmonary vessels, it is actually.
Ha. So it is not pericardium, but it is
no,
pulmonary
no,
vessel.
that is very difficult to say. You know, you see the vein there
Yeah, correct.
already, but the vein is going, you know, directly to the heart.
Correct.
And from there you can, you know, see what is the extent of the growth or the fibrosis of the tumor, you know, in the pericardium, you know, in the pericardium.
I understand. I understand.
So sometimes we do that, you know, because that is the problem. You don't know exactly, but there is
Correct.
only
So
fibrosis.
he is
Of
almost
the,
doing it actually, almost with a disc of tissue left behind. It's almost done actually.
yeah, that's the point. Yeah.
So you can put a gauze piece just across and pull it. That will help more.
Yeah.
So what about the bronchial artery? Ligation of bronchial artery, is it routinely done or?
Ideally, it is not done routinely, but in such kind of scenario, you don't have a choice. If it is going vertically and it is infiltrated by the tumor, then you don't have a choice. Actually,
Can you imagine this situation with a tumor around the carina? Eh? That is.
at least it is little below, so we are quite safe.
No,
But
that is very important, you know, to see the differences. The tumor will be around the carina. The operation will be almost impossible, you know.
impossible, correct. Otherwise, you cause a rent actually.
Yeah, of course, you know. Do you think in sometimes will be an indication for conversion, or do you think no, impossible?
No, there is in conversion. What I feel is you won't achieve anything extra. Whereas with magnification, any type of thing can be witnessed except a major vascular injury. And even in major vascular injury, if you put a gauze piece, just hold it for little longer time, I think it is going to help you.
I do agree completely with you. There is no indication for conversion, with the exception, you know, of a very big bleeding or a vascular lesion, you know.
And the
You
what I
have to
was
solve
referring
it.
to, Jagdish, is like at this point, at the lowest part, I always look for the thoracic duct on the anterior side, not on the posterior side. And
Yeah.
usually I get it in almost all cases. And I'm very fond of putting two clips going above, that's all, but prophylatically. But fortunately, we never had any thoracic injury in our 200 cases, because if we don't see, we don't put actually. If we see, then only. And this is the area where Sir is showing. This is the place you will get the thoracic duct actually.
And I think that to clip the duct, the thoracic duct, will be 3 centimeters above, you know, the sinus. Because there is a lot of branches distally of the.
Correct. Correct.
Sorry, I lost the live imaging, so now everything is good. But
now
I
you are
lost
getting
completely the
everything, sir.
discussion, you know.
Now you are
almost
getting
5
the
minutes.
image.
No, still
now
some problem.
everybody
It is not. No, I don't know. Very nice ECG because a striker. No, this is one.
No, that's okay, sir. That's okay.
That's okay.
And your planes are too good actually, so I don't think it is necessary, because now we are going to the left side, just behind the ajagus. Professor Cuesta, some people just put this ajagus one clip above to the pleura. Do you practice that?
I think, you know, if you want to do a very good supracarinal lymphadenectomy,
Correct.
like I think that the Professor Palanivello is going to do, I think gives a lot of advantages, to put the stump of the acigus vein up. And that is not difficult at all, and it gives you a lot of how you say,
டியூப் வச்சிருக்கீங்களா
it gives you, it facilitates the operation without any risk for bleeding,
Yeah.
of the acigus vein. I mean, you do that or not?
I don't do, because I do a complete transaction of the ajagus vein, and plus both the stumps I mobilize completely for two reasons. One is that your supracanal dissection will be much easier. The other reason is when you do the conduit part, later on when you give the conduit, if you have a wider space, the conduit exactly sits between the two clips of the ajagus. Otherwise, what happens is whenever you have not dissected this ajagus completely, both sides, then these hemorrhages, they press on the conduit actually.
Yeah, but you see that Professor Palanivello is tilting up, the stump,
Yeah.
and the space is more open and more clear to be dissected.
That is the same thing I do actually, so that even the lymph nodes you can take, and for the other thing is that you wide open the space so that your conduit is very well placed later.
Yeah.
No, Rudraji, you mean just clip it and leave it?
Yeah, clip it. No. I always cut the ajagus.
No, not you. You asked the question. Just clip it and leave it, you mean?
No. The anterior where sir is now touching the ajagus, they take a suture from the skin and lift the ajagus stump so that they can lift it. This is done by Japanese to see the left-sided recurrent laryngeal more better actually. That is what
I got it.
Yeah, but I never do this actually.
Yeah, I do that. Yeah, I do that, and I think I have a lot.
I have seen in one of your live where you have done it.
Yeah. Concerning the thoracic duct, I think that you have to clip it. And if you see that, just clip it. Yeah.
Yeah, if you see it's definitely you clip it.
Yeah. But we use, like the ICG in order to see where the thoracic duct is running. Yeah.
So I like the Professor Subramanian sir's method of ICG. He uses ICG 3 times. One is before entering to both the inguinal nodes. Then during surgery, he nebulizes with the ICG so that your airway is also seen with the firefly. And then he will, once the stomach tube is made, he will give it IV for the perfusion of the stomach tube. So 3 times the ICG used for safe esophageal surgery, where you can use the ICG. But
so I think Professor Palanivello is going to put
do your method of hitching the ajagus stump actually.
I like it.
He listened to you actually.
Yeah, I think so. But so you use the ICG 3 times during the operation.
Yeah.
I think it's okay, because
this is all actually depending on your institutional protocol. You can do actually. It's not a mandatory, but definitely if your institute is more fond of using the complete thoracoscopic and ICG, then it is okay. I don't know about Jagdish doing it
we always do, because it's a robot. I always prefer robotic for the hysterectomy, So we have Firefly inbuilt, and we always do ICG beforehand for thoracic duct as well as for the perfusion for the
For
conduit
perfusion,
perfusion.
But airway is a
Airway is
new.
a new thing, but
It is
the
a new
damage to
thing
the
that has
damage to
come
the
after.
airway. Yeah, I know
Yeah,
that. Airway damage
Anuma.
most of the time is ischemic necrosis over the posterior membrane. And
correct.
even if you see, it's the way we handle the trachea membrane is more important.
More
But it's
important.
another tool, especially for the younger ones. Nothing wrong in trying that.
Yeah,
But thoracic duct and perfusion, it definitely helps.
definitely.
Gas piece,
100%.
Because it's inbuilt, it doesn't cost another 1,500 rupees more. That's all. So
Yeah,
it's
that's
used
all.
routinely
That's all.
for all colorectal and GI cases. We always do routinely.
Yeah.
I think like where the nebulization helps is when you have a difficult tumor at the carina,
Correct.
particularly when you're doing a salvage esophageectomy. I think in those situations, it may not be mandatory for every case, but
Every
in
case.
difficult situations near the airway, I think that is the real use of it.
Correct. So you see now the azagus vein stump is away from the site of surgery. So that is how the advantage is.
I like it, you know.
Yeah,
I
yeah.
like it because the space is
The
very
space, it is
visible,
always
very
falling on
approachable.
your site of entry. Yeah.
Yeah.
The thoracic duct.
Yeah, the thoracic duct is there. Yeah. Yeah, you have to clip it. Yeah.
Just for
But
the record,
you are just, if you are remaining paraesophageal, it's not required actually. There is no need to search actually.
You know the point is that that you have to do a very complete, you know, supracarinal lymphadenectomy now, and that is definitely very important, and sometimes, you know, in Europe, doing the Ivor Lewis operation, we see that the people refuse to do the supracarinal lymphadenectomy in the case of the Ivor Lewis anastomosis. But we are discussing this point very broadly because we think that you have to do always the lymphadenectomy along the recurrent laryngeal nerves.
Yeah, yeah. Because you see, whenever you have a three-field esophagectomy in a mid-thoracic esophagus, it is very important for this part of the lymph node dissection. And Jagdish will agree that after robotic, this part has become more easier.
I do agree with you, especially on the left side.
Left side, correct. Jagdish, any experience?
Yeah, actually, first thing, let me acknowledge Professor Costo, sir. As a postgraduate, we used to watch your videos, sir, online, and then we were brought up as a student, and also Palnivelu, sir, watching his thoracoscopy. We thank you. It's an honor to be in this podium with you, Professor Cousteau and Professor Palnivelu, sir. So regarding the question of Dr. Rudra, I found the azygous vein ligation and transection is helping aortopulmonary window clearance and the opposite RLN lymph node clearance very well. There are sometimes instances where we avoid lymph node dissections. We just do esophagectomy, especially post chemo RT cases. So such cases, I don't do azygous clipping nor bronchial artery clipping. But whenever I plan a nodal dissection, especially on the other side, it is definitely helping. So that's my take.
But
Jagdish,
after robotic, yeah, sir, please.
You can appreciate here thoracic duct.
Sir.
Close up, camera closer. Hey, this.
Some things
you can see the thoracic duct I traced here.
Exactly. Yeah, correct.
Yeah, and
yes, sir. Yes,
same
sir.
thing.
Yeah.
Same thing.
So suppose you think the tumor is involving, then you have to take it out. Suppose no
correct.
tumor involvement in thoracic duct, there is no meaning. Leaving it, but look at this side, as we already discussing, any leak of chyle or anything like that case, you put a clip. Otherwise, just we leave it. It is fine. Huh? That is okay.
Yeah, it's true. Sir.
Yeah.
True.
We agree with you. Yeah.
Yeah.
But very nicely managed, sir, with such difficulty.
I think the other case, which I did abdomen, Ivor Lewis would have been better. But anyway, that case ready. That as soon as finished, I am going to start that one. That may be better to appreciate. Already dissection of the lower and esophagus done through abdomen. Maybe a good case for a demonstration.
Correct.
This is, I think.
But still, this case was done very meticulously. I think showing difficult case with Professor Cuesta around is also important.
But Professor Palanivello, we are learning a lot of you. That you know that, because I think
thank you.
Your way to operate and to solve
I think
this
I first went to
you need a lot of
Dr.
skills.
Palanivello in 1999. At that time, we went to see laparoscopy cholecystectomy, but daily there will be one case of esophagus. So from 99, I'm seeing him the same surgery. And at that time, he used to do lateral position. When later he changed to prone position. But I think the hands are moving same from that day to till today.
Hey, Rudra, I think I'm happy that you didn't mention that. Now the same speed is not there or something.
No, but I think it's very important. You know, the movements of the surgeon doing minimal invasive surgery, I think is very, very important. And I admire,
it is only the movements are very
harmonic.
Moving the hands and looking, behind the esophagus on the posterior side and going back, to the anterior and looking the anatomy. I like these movements, because that is the reason why we are surgeons and we have so many joy and pleasure, helping the patients,
Correct.
But it's not easy at all, you do for our patients and we are very happy, but you need, the manual movements and the rhythm. And that is very important, in minimal invasive surgery. That's the way that Professor Palanivello is doing now, Very, very good camera too.
Professor Cuesta, I have a question for you.
Yeah.
You briefly mentioned about the extent of supracardial lymphadenectomy for adenocarcinoma. So what is your current practice? Do you do supracardial lymphadenectomy even for adenocarcinomas or
bipolar
for
Yeah, we are doing that, So it depends on the case. If there is, a severe 2, there is no need for that. But if you have, an severe 1 or of course a normal adenocarcinoma, the amount of metastasis in the lymph nodes supracardial may be 20 to 30%. So you have to do that, Yeah.
Sure.
So we are doing and we are teaching the surgeons in Europe to do this very safely, and because there are a lot of ways, to do the dissection along the recurrent laryngeal nerves, and you don't need, to dissect the nerves completely. So you have to almost to do without touching the nerves, but you have to do, the lymphadenectomy also in the case of adenocarcinoma, with the exception of the severe 2.
Sure.
I don't know what is your idea, because I think in India the amount of adenocarcinoma will be very, very low.
Yeah, certainly
5%,
less, but we are seeing more. We are seeing
No, it's increasing
relatively
actually.
more numbers, but squamous cell carcinomas far outnumber the adenocarcinomas.
Yeah. That's very normal, you know. But can you imagine that in our case, is the typical case is an obese patient with an adenocarcinoma of the esophagus. So the combination of obesity and adenocarcinoma with an BMI above 30 is in 1/3 of our patients. So we operate very thick people with adenocarcinomas. Yeah.
So
So,
you don't do, Professor Samrasam, you don't do the nodal dissection for type 1 also?
No, we do, but I have to be honest that it may not be as extensive as we do for a squamous cell carcinoma. We definitely try, but do it much more meticulously if you want for squamous cell carcinomas.
but for the abdomen, you do a D2 gastrectomy?
Yes, sir.
Not a D2 lymphadenectomy, you mean?
Yeah.
We do for the adenocarcinoma, distal adenocarcinomas, a D2 lymphadenectomy, yes. Sometimes there is a big discussion about the lymph nodes in the ileus of the spleen, you know, but you can do D1 plus or D2 according, you know, with the anatomy, but you need a more lymphadenectomy than in the case of squamous cell cancer, yeah.
So, in India, the advantage is chemoradiation. So, a lot of people are getting away with not doing a very high supra-azagus, very meticulous recurrent laryngeal nodes because of the chemoradiation. But definitely, it depends on the location of the tumor. If the location of tumor is middle third, then definitely you need to do a better lymph node dissection on the recurrent laryngeal, because the chances of having a skip node above will be of the tune of 5 to 7%. Whereas if you have a lower third tumor, the chances is of getting a skip node is only 2%, though a lot of people are not doing. But my take is, if you have even one or two,
section which
just treat like a esophagus, do a complete 3-field esophagectomy. And if it is severe 3 or more towards the stomach, you more concentrate on the D2 lymphadenectomy. You will get more number of nodes, and you might get away with not doing a supra-azagus meticulous recurrent laryngeal
hello,
dissection.
Rudra.
Yeah, please.
Rudra, just I want to show the anatomy. I'm not going to clear anything. You
Yeah,
can
okay.
appreciate the right laryngeal now here. Huh?
Yeah, correct.
Yeah, we can see. Sir, I want to ask a question. Basically, have you changed the position of the camera, sir, for this dissection?
Yeah, I brought it. No,
But,
today this time I was using the lower ports most of the time.
Okay.
And here and the left paratracheal, better keep camera here for more for third one. Huh?
Yeah, sure. Okay.
So where is the camera now? Sorry.
Now this is the third port, is seventh space.
Yeah. Okay.
I'm working with the.
So definitely your angulation will be much better if you keep it lower, and you can see the apex more easily.
Yeah, I see that. Yeah, that's very good. Yeah.
Yeah. So Professor Cuesta, our ports are little lateral, but we are always happy in visualizing all the quadrants quite easily. I'm not sure. I haven't used your port positions, so I cannot comment. But we are quite happy with these port positions.
Yeah. I am happy to see that also, you know. And but you know, concerning the point of the necessity to do the lymphadenectomy supracarinally, I think it's very important to learn this. And if the surgeon thinks that the chemoradiation is going to avoid any supracarinal lymphadenectomy, that is not okay, you know.
That is
So
not true. That is not
that is
okay.
true.
Correct.
That is
Correct.
not true.
It is not okay.
That is not true, but the procedure is not easy. especially because the surgeon is a little scared about the lesion of the recurrent laryngeal nerves, and I can imagine that. But if you are esophageal surgeon, you have to learn properly, because otherwise you are not doing, the good operation for the patient.
Correct. The number 2 point is that how much of your patients have you found having a recurrent laryngeal injury, or you needed a tracheostomy?
Yeah, that's a very good point. In sometimes you have to. I remember, years ago that we dissect the nerves more or less completely, but there's not necessity for this. So you have to find the nerve very properly, very gentle, and to take down all the lymph nodes on the surface of the nerve almost without touching the nerve. That is the point. And on the right side and on the left side, like Professor Paranivelu has done with the right side. And if you do in this way, the mouth is perhaps 18% on one side, and it is always temporary. And that is very rare, the necessity, very, very rare to do a tracheostomy because the lesion on the both sides. I don't know what is your experience.
Yes, same. Around maybe 10 to 15%. In our series, we have done around 300 esophagus. So around 10% we had definite single side injury. And, but most of them, they recover. I think very rarely we have 4 or 5 patients, they continued with the hoarseness on follow-up too. But there was no need for tracheostomy. In our series, we had maybe 4 or 5 conduit failures in our series, where we had to again detach and keep the stomach tube in the abdomen, and I go back after 4 to 6 weeks with a colon. And in those one of the cases, the patient, although I had made a esophageal fistula, but the patient was continuously having microaspiration. So my pulmonologist advised to go for a tracheostomy. So in those cases, I had to do, which became a temporary, and later on, after I did the colon, at the time we closed it. It was not.
Yeah. And you use for this lymphadenectomy some neuromonitoring of the nerve?
No, unfortunately in India we haven't used. Tata Memorial Hospital is the first hospital where Sabita is using the neuromonitoring. I think Dr. George is also using, but I have no experience for neuromonitoring, but mostly relying on our visual perception and magnification.
But do you agree with me that we need to teach the young surgeons, esophageal surgeons, more in a kind of consensus how to dissect this part of the operation?
Correct. Because I had seen a lot of people initially when thoracoscopy started, they were not doing the supraesophageus part. They were simply doing the infraesophageus part, leaving it. And when they do the neck, they were just using the fingers to do the upper part, just like a transhiatal esophagectomy, which later on became more popular as we saw our stalwarts like Dr. Palanivelu, Dr. Subramanian Rao, they started, Jagdish, they all started doing the recurrent laryngeal node dissection, which gained popularity. So now even the younger surgeons, esophageal surgeons, are taking up this and doing it gradually.
Yeah. I think the part of the operation what Professor Palanivelu is doing now, I think that you can see in my opinion, the differences between the robot and the minimal invasive esophagectomy, like we see at this moment. Because if you use the robot, I think that the view of on the left side, is
much better.
Is much better. Yeah,
much better. Correct.
I think that I do agree with you. That is
and
the
this
point.
tap, using a tap to pull the esophagus is very much helpful when you go for the left side.
Yeah, of course, but but sometimes, I am trying to define for myself what are the advantages of the robot, and definitely in this part of the operation,
correct.
That is what I feel, I do the same operation as you do, Professor Planivelu, and sometimes, but I see the differences.
Yeah.
I also completely agree with the comments.
Yeah.
Correct.
And this, because it is a palliative, there is no point of going clearance all. Here. So I think I will separate and leave it. Next case, we'll at least show that something we can.
Yes, sir. Okay. Thank you, sir. Thank you. Very nice demonstration of a difficult case. Yeah, correct.
And there are different ways, to dissect the left recurrent laryngeal nerves, because the Japanese people try, to tilt up the esophagus in this part of the operation in order to find the recurrent laryngeal nerve. And there are, I wrote one paper concerning this point, and I found, 5 different ways to do
here now here is going down, but we don't want to take it unnecessarily. I think this part is over now.
Yeah.
Okay. This side also I completed. இது மட்டும் முடிச்சிடலாம்.
You did a beautiful dissection, Professor Planivelu.
Thank you. I never expected this difficult unnecessarily will be there.
Yeah.
But
when
we all discussed.
We thought
you all discussed very well nicely.
Yeah.
But your hands are marvelous, so you could go ahead.
Okay, this is a crura here. Okay.
Yeah.
And I have to thoroughly toilet the peritoneal cavity and the abdomen and the chest also. But we'll take it out the tape gas pieces. Bowl first. And
Professor Cuesta, there is a question. Do you have a wait and watch policy in CA esophagus after complete chemoradiation with a pathological response?
Yeah, and I look at immediately many of them will be negative by PET scan, but I will follow by 3 months, 4 months they become positive. And 80% of the cases become positive, maybe 3 months to 6 months. This particular case, it was actually negative. That's why you thought, completely gone. Now he is so much difficult with us. If this surgery would have taken 8 weeks to 12 weeks by the time, would not have grown to this level, no? Irrigation. So I always young people, and I'll recommend them, if no other risk, I'll go for surgery if a patient accepts after explanation. Irrigation, please.
Yes.
I think that answered the question. Professor Cuesta, any comments?
No, not at all, because I said before that the trend of this moment is to compare and to say wait and watch if there is complete response. But to assess that this complete response is also very, very difficult, because the lymph nodes, etc., etc. So my argument is that the mortality is very low of this operation at this moment, and you give certainty to the patients. Only in the case of very old people, you can say wait and watch, of course, with the controls. But I don't know, but I don't like this. And it is only for the squamous cell cancer, not for the adenocarcinomas.
Correct.
Professor Palanivelu, can you
Yeah,
show
that I
us
agree with you. Every case
the
need not
left?
operate, but we have to check it if it is a complete response. But follow-up is very important because majority of them will come back sometime later, and that is where I think. And some people comes after 3 years, but majority comes 3 to 6 months time. So that period we have to follow up, and early lesion, then we have to better to operate rather than waiting. Okay. Now what
I
I'll
do
do,
agree with you.
loop இருக்கமா அந்த நீடில் என்ன கொடுங்க 20 இருந்தா கொடுங்க பரவாயில்ல பரவாயில்ல கொடு கொடு and I'll be taking the specimen after taking instrument of the abdomen, and so that I can do it. But neck I will be using a protective sheath to take it out, and so that fear will not there.
Okay.
You will deliver the specimen from abdomen, na?
Yeah, above, but I'll show you plastic sheath how we use it.
Correct.
And plastic sheath goes from neck to abdomen, and through the plastic sheath it will be delivered outside.
Oh, very good.
So, Palvel sir, you're doing this because of the mucosal injury there, right?
Yeah,
You're
yeah.
just covering it up. Okay, sure.
Yeah.
No, definitely some spillage, something.
Yeah.
Yeah.
For the
And
spilling,
I'm putting it, that should not be, no, that is better. Some
Yeah, that's okay.
protection.
Yes.
Mhm.
Just regarding there's that question from the audience that specifically asks for adenocarcinomas.
Yeah,
So,
yeah.
as there is no role for wait and watch.
I'll ask you, adenocarcinoma, how many percentage complete remission? It is a very, very, very small percentage of complete remission. Squamous
Very
cell,
less,
yes.
maybe 10 to 20%. But
Yeah, yeah.
in adenocarcinomas, there is no role for wait and
Yeah.
watch. They
There is
already
no role for waiting watch. I do agree with
The
you.
major problem with esophagus wait and watch is in rectum you have MRI, which is a very good modality to have to declare a MRI radiologic PCR. But in esophagus, even if you do any investigation, whether it is PET CT or a CT scan, contrast CT of the thorax, you will not be able to declare a radiological pathological CR. Only what we see is
Inflate
endoscopic
பண்ணுமா
complete response, because when you do a endoscopy, you don't find the lesion.
என்னால
But
கேஸ்
we
க்ளோஸ்
are
பண்ணுங்க
not sure what is there in the wall of the esophagus. So that is why in
இன்ஃபைட் பண்ணுங்கம்மா
esophagus, wait and watch is not going to be that successful, because we don't have a proper imaging to declare radiological PCR.
I do agree with you. Sometimes you have to take very deep biopsies
open
in the esophageal wall.
stupid well, I'm working again tilting out these.
I think that the normal policy is in young people in good condition, do the operation always. In old people, you can wait and watch if you see the total response or the complete response. And in the case of adenocarcinoma, you have to operate always.
I just have a question for the anesthetist in the team. What pain relief have they given? Like, is it an epidural, paravertebral block, intercostal block? What kind of pain relief is the routine there? If somebody from the GEM OT can.
he can help us in asking this question about the anesthesia. Any anesthetist can respond.
Maybe
they're busy, maybe in the other OT.
No, they're planning to shift from this OT to the other OT. So I think so they're a little bit.
That's okay. That's okay.
Yeah.
Okay. So usually for the pain relief, we usually give sensor can at the port sides, and later on the patient is taken care with the pain control anesthesia actually.
We've started using paravertebral blocks, sir, and they seem to be working very well. Compared to the epidural,
Jagdish, any experience on pain control?
Data is conflicting, but we are using epidural.
Yeah.
And as well as the port site infiltration.
Yeah, same thing. Same thing what I told is epidural and port site infiltration.
But I do agree with Professor Samarasam that the paravertebral is better.
Good.
You know, paravertebral use of
particularly hypotension post-op.
Yeah, I do agree with you. Yeah.
Another question I want to ask Professor Cuesta, with the use of robot, because you see, when we do laparoscopy, it is our hands which put the pressure on the port. So the port site, when you put the pressure, it is controlled by the surgeon's hand force. It is not a uncontrolled one. But when the robotic arm is doing the surgery, I think it is using quite more pressure than a human hand. So do you feel that the pain score in robotic cases is more, or you feel it is not very
different?
Not at all making any difference?
Until now, we don't see the differences in the pain control between the normal laparoscopy and the robot. No, we don't see that. No.
Yeah.
Not at
because you see, robot also use what is called as laparolift. Yeah. So it helps in lifting the abdomen. So constantly it is keeping the. That is why the robot is lower in entry, and it just lifts up. That is the way it works actually. So
and that will be more painful.
That will be more painful as per the ergonomics. But are we finding that in actually? That is my question.
Yeah. I don't know exactly. You know, I think it's
because in both cases we give sensor can. Both cases we use epidural analgesia. But I asked my anesthetist if the requirement is high. She said yes, the requirement is higher than laparoscopy in epidural requirement.
So you will say that perhaps it's better to combine the robot for the thoracic phase and the laparoscopy for the abdominal?
Yeah, hybrid. I feel that now the time has come, because you see, ultimately, what is our aim? The aim is that where there is a difficulty and the armamentarium we are using should show us this place very easily, because everything is that it should give comfort to the surgeon while operating, and your fields are very clear, you manage it well. But ultimately, when the pain control, everything is taken into consideration. I think if you do the abdominal part laparoscopically, it might give less pain. And ultimately, if it is not helping that much, I think thoracic part robot and abdomen part laparoscopy is not a problem.
No, I do agree with you. I think the time comes, you know, to select better the approach, and sometimes to consider that the laparoscopy will be enough, you know, of good enough for for the abdominal part, and for the thoracic part will be better to use the robot, especially for the upper part of the thorax. I mean, for the supracarinal part,
Yeah,
you
correct.
know, and that it will be, I think, will be very, very clear, because the robot is not, able for everybody, first of one, and everybody thinks without the robot it's impossible to do the operation, and that is not true. So we have to do little by little to implement the robot according to the financial possibilities, but to use the robot in selected cases, at least in the beginning.
I didn't find any difference whether we do laparoscopy or thoracoscopy, and I would prefer both abdomen and thoracic robotic only, because I found it very easy to develop the conduit and develop the plane of the gastric epiploic and the posterior part of the stomach. We can lift it up and do dissection of lymph nodal dissection. Maybe Rudra can come out with data, then we can get to know it better.
No. Actually, you see, you are doing robotics since long. I just started. So it is not, I'm contesting anything. I was just giving a suggestion. But definitely, when I do more, I might find it more better because you see, I have a limitations that I'm with a Hugo Ras, where I don't have a stapler. So I manage it definitely through an extra port. So when I say that I use an extra port for firing the laparoscopy to do the conduit, then why not I do the abdominal part laparoscopy? That is why I'm in that mode. But maybe if I use Da Vinci with a, or they're coming up in March end with both Ligasior and this Firefly and Stapler, at that time I might again change to complete to abdominal part also robotic. So,
I think, in my opinion, the robot, the advantages of the robot are the dissection of the supracarinal left side, and to do in the Ivor Lewis operation the manual anastomosis that you can do very high in the thorax. In my opinion, that is the most important. For laparoscopy of the abdominal part, I don't see directly any advantage, with the exception that you tell us about, the upper part, on the hiatus, but I'm not sure of that. I don't know what you think about it, of the real advantages of the robot.
Professor Samrasam, there's a question, I think, because you use a paravertebral block, the audience is asked the dose of the bupivacaine.
No.
Okay, so basically the question actually, one is regarding the chest tube is directed up or down. Usually it is directed, towards the apex. Regarding the paravertebral block, see, the advantage of the paravertebral block in preventing hypotension is the fact that it is unilateral. So you want to, if you give an epidural, obviously, it is bilateral effect. Whereas when you give a paravertebral block, it is the right side which is going to be sort of, so therefore more than the dose, it is the site and where it acts which determines the occurrence of hypotension. So the incidence of hypotension is less. Professor Kusto,
I do agree with you.
Yeah.
I do agree with you. That is and that is very easy, to place in the thorax, because the surgeon is doing that. That is not necessary to the help of the anesthesiologist, putting epidural or whatever, but you can do the paravertebral by yourself, and place, the tip of the catheter in the proper place in the thorax. Yeah, I think that's very real advantage.
Yes.
There is also a second part of the question where The audience wanted to know whether you will put a prophylactic left side as well, chest tube.
What Dr. Srijan here. So generally, after the dissection, lymph node dissection, there can be some amount of lymph secretion coming from the thorax, and it will be pulled up in the lower part. So I always direct the chest tube to the lower part of the chest on the right side, and sometimes we come across injury to the pleura on the left side. But if a small injury is there, and if there is no saturation fall, I usually don't put a chest tube on the left side, but the standing instruction is that if there is a saturation fall in the postoperative period, definitely a patient requires a chest tube, and a close monitoring always it is done. And so if saturation is falling, definitely we are going to put the chest tube on the left side.
I have a different viewpoint that in all my esophagus, in all 100, 300 cases, we put on both sides. Because you see, if there is a small rent in the pleura, then some collection will be there, which will hamper the recovery. So I always put both sides, but left side always is hardly anything comes out. In 2 days, it is out. And on the right side, it usually comes out in 4th day or 5th day. So it is not a point that putting extra left-sided tube is going to make any difference, but at least whatever is there will come out. And whenever you are giving a pleural cut, both anterior and posterior, and especially when you are doing supracarinal complete dissection on the left side, there are always chances that left pleural cavity will also get opened up, and this will get communicated, and some collection will be there. So my point is always do the ICD on both sides. Even if some cases very old, I have done a transhiatal, and old people or frail people, I do transhiatal to just to complete the procedure within 2 hours. And in those cases also, I put bilateral ICD always.
So, but is it mandatory? Because I've been
No,
doing
no, it is
transactions
not
for a long time.
mandatory, but it is safety actually, because
Yeah.
you don't want to go to the theater again or in the ICU again. There will be a call and you want to put. So my practice have been bilateral ICD in all esophagus. I think Dr. Mohan Prasad, Dr. Cuesta, all can give one line answer to this question.
Maybe individual differences are there. I've never put chest tube on the left side after thoracoscopic or transhiatal unless it is indicated. That's my view.
Yeah.
I do the same. I do not systematically on both sides. Only if indication to drain the left side, but that's usually very low percentage.
Yeah.
But in the case of transhiatal, and that's very important discussion, if you open, broadly the pleuras on both sides, perhaps you need to put the drain also on the
Also
left,
on the left
the
side.
left side. Yeah.
Correct. Dr. Mohan Prasad, sir?
So you're muted.
Dr. Prasad, you are muted. You can unmute. Still not audible.
Yeah. I prefer both sides drainage. I am muted on both sides.
No. So that's okay. I think it is a classical difference between surgeons. I think both sides, a lot of people put just for safety, actually, nothing. Because if you analyze in our series, left side, the output is always less. And on second only, we take out the tube. But it is our, maybe because in centers where you feel that you get a call, then you go and do it. So just to avoid that, we put it and take it out on third day, and fourth, fifth day we take it out on the right side. So that's the usual routine.
Okay.
I think Professor Panelvendu is ready with the second case.
For the second, yeah, for the.
Yeah. It is very heartening to see that previously when we were doing in our residency days, Jagdish will remember, that when esophagus is going to be done, we were sitting in the OT from morning 8 o'clock till 4 or 5 o'clock when things get finished. And it is now heartening that the thoracoscopy part is in a most difficult case also is done, I think, hardly in 2 hours. So that is the beauty of thoracoscopy and robotic. What do you think, Jagdish?
Yeah, true, sir. And second thing, I was in Kidwai where we studied 254 cases. So I personally, I feel the case selection has become better over a period of time. And second, the handling of the tissue has become very delicate, very careful, and the perfusion and the conduit, all those things have been very standardized. So standardized, simplified technique has improved the results, I feel. So all surgeons have become wiser.
Even the anastomosis.
Yeah,
Earlier,
understand.
so many type of anastomosis were described, and we were so much confused. Somebody telling Gambis sutures, somebody telling parallel mattress, somebody something. Then finally, the PDS came, made all simple sutures, and later on the the stapler we use for the posterior wall, and we create a complete anastomosis. I think things we were became more clever with more cases being done actually. Yeah.
No, I do
Yes,
agree
sir,
with
we're
you
with you.
that with the development of the minimal invasive esophagectomy, the developments in technique and in the type of anastomosis and therapy, etc., that is are going so rapidly and so.
ரொம்ப கொஞ்சம் தள்ளி எடுத்துட்டா போடும் 1.5 ஸ்பீட்ல வைங்க.
Professor
Pallavelu, sir,
Palanivel,
we are with you.
are you operating never in French position in the legs, or you prefer to operate on the left side of the patient?
Professor Palanivel,
Hello, Mister.
you are with
Rudra, can I show the video sometime the stomach or go to chest excitable now? I'm ready.
yeah, you can
Yeah?
you can, we are ready, sir. You can go
Yeah,
ahead
then
with the
go to chest. I'll show the video later. It is a 30 minutes video of gastric tube formation, the same patient. I did before coming for the other PA patient, I did abdomen, made a gastric tube come back and push inside. Now video math Pashupati. Hello, Pashupati, video math. Are you getting video now?
Yes, sir, we can see the video.
There is an addition to the lung, like previous some infection, like you would have seen this upper lobe, and just releasing it, then before going to this. Lower abdomen is fine.
For the benefit of the audience, this is another case where sir has already finished the abdominal part. The initial part, what we saw is a video of that. So that has been switched off now and we are into the thoracic part.
I will show the abdomen. It is a nice gastric tube formation. I think postgraduates may appreciate it. After end of this, I will show, and anybody want to stay, then they can see. Harmony Kuduma.
So your port positions are the same,
I
sir.
am.
For this,
Pardon?
your port positions are
Same
the
port procar same. No, I am putting the upper 5 mm now.
Okay.
Sister knife. குடும்பப்படுத்தினது போட்டேன் கையில் பிரஸ் பண்ணி பார்த்துட்டேன். This is 5 mm. I made it. Now harmony. Camera here. இந்த ஷீட் எடுத்து போடுமா, கிளிப் போட்டுருமா, 2 கிளிப் எடுத்து போடுங்க. இங்க ஒரு கிளிப் போடும். நம்ம 7 கொடுத்துருக்கலாம் பாரு. எங்கம்மா காட்டுக்கிட்டேன். Gas face. Sister, gas face. This side. பரவாயில்ல, நான் வச்சுக்கிற வீட்டு கையில் வச்சுட்டு வாங்கிக்கிறேன்.
So there is one question.
Yeah.
Any use of JP drain instead of a water seal in thorax?
Sister, இந்த பக்கம் டேபிள் ட்ரீட் பண்ணுங்க, ப்ரோன் லிட்டில் மோர் ப்ரோன் பண்ணுங்க. What is the question? Can you go ahead?
JP drain instead of a water seal drainage. I don't think it is ever used.
Not the same.
JP drain is mostly used in the abdomen. Thorax is always a water seal drainage.
I use the GP drain also in the eye for Louis operation.
Yeah, correct.
Yeah. But only, along the anastomosis.
Who could think ma?
Nearby the anastomosis.
Yeah.
கவுட் எடுத்துங்க. கிளாஸ் பீஸ் கொடுங்க.
This has more lung adhesions, I think, this case. So whenever you see such type of thorax, when you see that the lung is completely adherent, never ever jump to never ever jump to the esophageal part. First do the adhesive lysis completely and take the lung down, and then you can do anything, because otherwise you are not going to get any space.
I do agree with you. That is very important, to dissect the lung free before you start the operation, because otherwise that is impossible to see the planes or to do a proper resection. Never.
Yeah, correct. But in India, this is very common actually.
It's very common. And the combination of the all tuberculosis and I think in India is more frequent than in Europe.
Yeah. And they are sometime might have history of taking the treatment, but they may not reveal. And ultimately, when the surgeon goes inside, you have a lot of infective lung where you get such type of adhesions, and you are stuck actually.
So you have to be very careful, with the lung, because sometimes you will get some leakage.
Table raise பண்ணுங்க.
Leakage
So
after
they are called
operation.
as peripheral lung injury. So if it happens, then there are so many things to be done.
You have to resolve it, to solve it. Yeah.
You might need a stapler wedge resection. You might
I do agree with you.
do a glue, or you might take one suture. A lot of things are there.
Sometimes, especially with the bulle, or sometimes of chronic problems of the lung, and if you
COPD
make the
patients.
injury, you will get a leakage, for weeks.
Have you seen the type, the way sir folded the lung just to see that is there any posterior adhesion or not, and immediately he's away from it. So that is the beauty. That is the beauty actually.
Closer.
No, that's delicate.
Yeah, because the adhesions, under the adhesions, you might find some bronchial vessel going, and
Able to appreciate such a big node sitting here. I don't know why that imaging or none is picked up.
I see that.
Node on the just near to the tracheobronchial junction on the right side actually.
Yeah. I think it's a high lymph node. Yeah.
This I don't think we'll be taking out. We'll
very
see.
big.
I will try my best in that node. If you take it out, it's fine. And who could?
It's a very high.
Yeah.
Very high.
Even tumor here, which I mobilized, I'll show it is a very hard tumor. And but I could take it out almost 90% tumor through laparoscope. In the upper edge of the tumor I have to, but it is free from pericardium and vessels.
Correct.
Yeah.
So there is a question from Dr. Sumit Saha from Pune that which type of tube used? I think it is single lumen.
Pardon?
What type of endotracheal tube used? It's single lumen.
Regular single lumen size I will ask them.
Yeah. And the other one is how much is the tidal volume?
I will ask anesthetist talk.
So if you keep your pressures at 10, that also helps in keeping the lung down, because when you are using a single lumen, you have to keep the pressure little high. If you are using a double lumen, you can keep it at 8.
Double lumen, we don't do double balloon any. We stop.
Not required.
Yeah.
In prone position, it is not required at all.
Yeah.
So I think we also do the same.
இப்படி காமிச்சிட்டுனா கீழே வந்துட்டு நேர தட்டி இல்ல மேல இருந்தே பாக்குற மாதிரி பாரு.
There is a question from the audience. Tips for the subcarinal nodal dissection.
எங்கம்மா தள்ளி வைங்கம்மா, காற்றை தள்ளி வைங்க இங்க காலுக்கிட்ட.
So this step newcomers never do. Sir is scoring the fossa over the ajagus with a hook.
Yeah. Bipolar?
So now sir has taken the bipolar, because when you are doing this, underneath of the azagus, always you will find the bronchial vessel, and sometimes it might tear. So you have to be always be ready with a bipolar to do the bipolar of all the tissue that come out posterior to the azagus vein.
കേൾക്കവിടെ പോടും. என்ன குடும்பம்?
Some people said that you can preserve the azygos vein arch.
Yeah.
But what do you think about it? We never do that.
Well, my take is, if we are not doing a supraesophagus lymph node dissection or along the recurrent laryngeal, you can get away with it. But whenever you are doing a supracarinal dissection or supraesophagus dissection, I think I
You have
always
to do
needed
that.
to divide to see it better.
Regular clip.
Yeah.
அடுத்து சிசர். ரெகுலர் கிளிப் கொடுத்துட்டு அதுக்கு ஆர்டர்ல கேட்டுட்டேன் அதோட. அது எடுத்துரு. கொடு, இன்னொரு கிளிப் கொடு.
This can only be done by sir actually. We all will take out the clip and go for a fresh application.
கொடு, வேற கொடு. இப்படி கேட்ட. Hey.
So to briefly answer the question about lymph node dissection,
yeah, you can. Yeah, go ahead. Yeah.
Yeah. So very simple that you have to be very careful about the airway, and when you are approaching that part, if your esophagus is intact and your periesophageal fossa is adherent to the nodes, it is very easy that when you do the traction of the esophagus, the nodes will also get pulled, and you can dissect between the carina and that part. But sometimes during the process of dissection, your esophagus will get separated, and the nodes will be lying there. So which you can take it in a separate as a group of lymph nodes and do the dissection very meticulously. But always keep a bipolar ready, because nodes are not only the nodes, it is the nodes, they have a capsule and they are supplied by vessels coming below to these nodes. So whenever you do such type of dissection, chances of getting bleeding is always there. So it is always, you have to be very, very meticulous about the vascular pedicles going to the nodes to be ideally bipolar, and then you can definitely take out that chunk of nodes as subcarinal group of nodes and do a separate mapping and send it for the histopath.
So subcarinal nodes are located in between two bronchi, and there is always a midline vessel from the junction of these two bronchus. So if it is difficult, especially in India where a lot of tuberculosis is there,
Harmony Kurma.
we can start lower down and pick up the lymph nodes from the
Sir,
below
hook
and
down,
lift it
hook,
up
hook.
and then do the dissection from
Table,
underneath.
no, raise panel.
And
Correct.
then be very careful near the bronchus
Yeah.
and especially at the carina. Most of the time, this vessel oozes. So people try to do repeated cautery and damage the carina, which can cause incessant cough postoperatively. So these 2 points are very important. If it is start below and lift it up, and be very careful around the bronchus, and especially be very careful of the median blood vessel that comes from the
Is it?
carina.
Yeah.
I hope that
So that's
answers
why I
your
said
question.
that always be ready
அதெல்லாம்
with
பண்ண
a
வேண்டியது
bipolar.
இந்த புக்கம்
If
இறக்கே
that vessel is there, two
போதும் போதும்
bipolar, no monopolar, no ligation at that point, because that will touch the carina, and definitely there will be some ischemia in that part. So again, sir has started the dissection with the pleural cut.
மேல கேமரா மேல up. Now this is a bronchus bifurcation, trachea bifurcation, and this is left bronchus.
Correct. So what you immediately see is always a left bronchus, because
What?
your vision is end on. So always left bronchus seen. For right, you have to come towards this side to
Yeah.
see the right. So what you see immediately is carina and left bronchus.
Mhm.
This side camera first.
I like the way that how do you use the hook. I
Yeah,
like
correct.
it, because the hook is also, in my opinion, the best instrument that you can use for dissection.
I use all type of instrument, and particularly robotic surgery when came, I used more hook, and many
Yeah.
of the robotic surgeons says, no, we were using scissor, you are using no.
Yeah. Yeah.
So now also on right side,
And
I have always
because
the
this instrument,
monopolar
one
seizure.
instrument will be pulling towards us, no structures will come in between.
Yeah, correct.
Yeah.
Even
The same
harmonic when
thing.
used, it may
The
touch the
same
other.
thing what you taught us in laparoscopic cholecystectomy.
Yeah.
Pull and burn.
Okay.
Pull and
அங்கே வச்சுங்க இன்னொரு நல்ல கேஸ் பீஸ் எடுத்து வச்சுங்க.
We say to our residents learning the laparoscopic cholecystectomy that you have to use the hook as a painter. As a painter, use the small brush in order to dissect very carefully.
The same lines are told by Professor Bill Held in our last conference at Vellore, that use the robotic seizure, closed one, just like a paintbrush. So you just paint it like this. It will automatically show you the plane of dissection. So surgeons should be good painters actually. What if I say the
we
painters,
are very good painters, yeah.
So if somebody is a very good painter, he will be a very good robotic surgeon or laparoscopic surgeon.
I do agree with you. I think the artistic qualities, of the surgeon are very, very important. You have to be like an artist, but at the same time, you have to take decisions, And
bipolar கூட கேமரா இதுல போ.
How do you think in India
கொஞ்சம்
now?
ரைஸ் பண்ணுங்க, அந்த ப்ரோ நம்பர் கொஞ்சம் அதிகம் பண்ணுங்க.
There's,
How do you
there's
think
one
in
more.
India now? Oh, sorry, Professor Palanivel.
Just on the same note, there is one more this thing about the hook. You know, it's like a magic wand. So you can do so much of work, and looking Palnivel sir work like a magician. That's using a magic, the magic wand, which is the hook.
That's true, But what do you think in India now, with all the virtual realities, artificial intelligence for surgery, and the augmented reality, and all the overprojection of images in especially doing robotic surgery. But you are very advanced country concerning these points. Are you going to implement this very, very quickly?
Yeah, to answer that, I think recently we had one conference at Delhi with SSI Innovation, the Mantra robot, and they have come up with the Google HoloLens, and also that they showed the remote control surgery from the hotel. The robot was in their factory, and they did some dissection on tissues. So but there was a lag. So definitely this AI and this AR and VR are going to help. But especially what I found it more utilizable is doing training. You see, from when we were in general surgery, in earlier days, we were seeing open surgery, seeing on a stool how a professor is doing the thoracotomy, how he's entering, how he's taking out the esophagus and all that. That when laparoscopy came, everything was seen by everybody in a big monitor. And the same way now, robotic, you have 3-4 3D monitors, and everybody is seeing 3D vision. So the things are changing, and definitely when Google HoloLens will come, the robotic image will be transformed to the Google HoloLens, where artificially the image can be created, and the assistant or whoever is learning, he can observe 2-3 cases on a Google HoloLens where it is the same procedure, and later on he can do the procedure. But similarly, even remote control guidance, let us say I want to do some step, and Dr. Cuesta is having the Google HoloLens there. So
I understand.
my vision will be replicated to Dr. Cuesta's HoloLens, and during the surgery, whatever command he gives verbally, it is going to the surgeon who is operating, so he can take all the advices. So with this, what will happen is, after you give a proper training, you can hand hold your trainee by doing a remote control Google HoloLens assistance, and take through the surgery in 8 or 10 cases, and later on he can become a proficient surgeon. So
I understand what you mean.
definitely this is going to come in a big way, and AR and VR with virtual reality, I think everything can be created at a third space. The whole thing image can get created, and it is going to help in a big way. And remote control surgery will be also successful, but it needs more development, because the lag phase what we are finding between the surgeon command and the action on table at the site of surgery, there is a lag phase. So the surgeon has to get oriented to that lag phase, and then I think it can come, but there is a long way to go. It is not going to come so easily. But what I am proposing, I think in our group with Jagdish, we had small chit chat on this, is image integration in the robot. If your images, whatever CT or MRI, like for rectum, anything you have done before, if it gets integrated in the robo,
I think
and
in the platform,
once you put the ports, if the robo can guide in some way with the with the images, not to injure the majorectal fossa in a rectum or in a esophagus, airway, or anything, image guidance, if it can help, that is going to be the best for the surgeon, actually.
like a kind of Google map.
Yeah,
Yeah,
correct.
Rudra, there are some disclosures about this. What happened is earlier in UK, a robotic surgeon went for mentoring for a cardiac case, and he went for a coffee out, and the mentee injured the vessel, and there was a death. So the mentorship through remote is not going to be possible in the near future because of legal implications.
Correct.
And remote surgery will not be a possibility because in case some complication is there or anything is there, the surgeon needs to be in the OT. So
OT,
I
correct.
see it's a very long process. And AI and virtual reality is already there in Da Vinci, where there's an iPad. Next to that, you can inculcate the anatomy into that, but the robo is not fully autonomous. The FDA
Correct.
doesn't give approval for a fully autonomous robo as of date.
Yeah.
So remote surgery is not a near possibility
Is it?
because of a legal implications. It can be used for mentoring on a cadaver or
Yeah.
a model, not on a human body.
Yeah, that even if that happens, then also it is very good, actually.
Section kuda.
But I think in the future, the law will change because, the robot and, are coming so strongly and so fast that we are going to change some concepts concerning the law and concerning, the surgeons and the assistants and the tutorship, etc., has to change.
Yeah.
A very beautiful dissection, Palnivelu sir.
Beautiful, yeah.
Beautiful for the
Yeah.
node. Actually, big node, I think.
Very big,
And that is also just behind the carina.
Yeah. Yeah.
So there is a catch for the audience. Don't try this at
As
your
a
play.
first case.
It is only for experts like Professor Cuesta or Dr. Palanivelu.
Hey, they don't want to do it.
No. My take is, if we try to do this kind of things, I think we might injure, but your hands are totally safe.
Beautiful dissection, yeah.
Beautiful, actually.
Yeah.
Actually, as age-old saying is, everything happens in the human brain, and it gets just converted on
Section?
table. It gets
Yeah.
converted on table.
Rudra, is it a thing, necrotic tissue, or it is a
Then necrotic node, sir.
Necrotic,
node,
yeah.
definitely. It is post-chemo radiation, so definitely it will be a necrotic node. So nothing to worry, actually.
Got a liquid, yeah.
Yeah, it's a pus, actually, necrotic material.
Yeah,
So
I
it
think
will
it's
be there. But
necrotic.
once you suck it, it might become more easier to take out.
Yeah. Yeah.
Does it look like
Rudra,
incision?
one patient, Rudra, I will
Yeah.
not say that every advanced case to operate,
Yeah.
but if it is feasible, surgeon experience is there, if you operate, it is not that hopeless. And
No, sir,
this
it
type
is
of
not
people
hopeless.
responds well later on.
We have found that with that also, people are living more than 5 years, and that's where you got everything, actually. And who knows, it might come a tubercular.
Yeah, it looks like incision, which is yeah.
Maybe.
If
Like
it
a
is not
KGM
going to
came
come,
out.
then I leave it, then no other way. Now, if it is
Yeah.
coming, we have to take it out. This
Yeah.
is the bag is now going up,
Yeah.
and this has
So
to be
there was a
placed and
question
left it
by
out.
one of the students, one of the delegates, is where you are going to divide the Vegas?
The vacancies are usually divided below the asygosphere vein because the pulmonary and the cardiac plexus nerves are given above that. So always the division should be below the
Exactly.
yeah,
Very,
below the
very nice
cardiac plexus.
answer. So please note it that it is always divided below the azagus arch actually.
Rudra, should I leave it or take it out? All opinion. Whatever you all say, I will do it.
So you can leave the posterior capsule if it is not coming that.
Yeah,
Otherwise,
do it out. Yeah.
it is already you have actually taken out.
That should be
I,
taken out
I,
before
I
the
think
bed
it,
is out.
I think
So
it,
if
I think it's
it is
always
only
taken out.
advantage
Yeah.
is if you take it might come out infective or something else, but if it comes tubercular, the patient will be benefited.
I think so. You know, I think it's almost
Almost out
Almost,
actually.
yeah,
almost.
You
you'll
can
take it.
leave the medial part if you want. Otherwise, if it is coming out, it is always good because ultimately you will have some histopath and
Is it possible to differentiate this lymph node by the PET-CT between tuberculosis and a malignant lymph node? Do you think some special characteristics or whatever?
yeah, definitely it is there. The characteristic of the lymph node, the KGSN, the cavity with the pus, they are all indicative of a tubercular. But the other most important point is the FDG value. The FDG value
Hormonal.
usually you get in malignancy is above 5, but
Yeah,
if you get around 4 or 5, it is likely to be inflammatory. And
inflammatory. Yeah,
yeah, if it is above 5, like 6 or 7, it is
yeah.
most likely going to be
Malignant. Yeah,
malignant.
yeah,
So
yeah.
that is one point. The other point is characteristic of the lymph node, whether it is showing the capsular pattern and how much is the
The type of
KGSN,
infiltration. Yeah,
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 solid cystic component.
yeah.
That is also
Yeah, I think it's important. Yeah, also, you know, because I remember one case that I operated years ago in India, and the patient had a big cavern, tuberculosis cavern in the upper lobe, and it was so a strong inflammatory reaction with fibrosis. It was, you know, I remember the case as an historical case in my, you know, the very strong tuberculosis in the upper lobe of the patient, you know. That's amazing.
Bipolar.
Yeah. I will ask myself, where are the recurrent nerves in this case, you know, Professor Planibello?
yeah.
That is very far, you know, I think, but yeah,
This
that
seems
is
to be on the just above the carina on the.
Today is not a good day for me. Both the cases somewhere.
oh no,
I
sorry, because
understand.
I on the that is a carina. Yeah, sorry. I was thinking about, you know, another position. Yeah,
No, no, no.
Yeah.
This is Karana.
that is carina.
Karana, correct.
No, no, I know that. Yeah, sorry. I was thinking about, you know,
Sir, with Professor
that is
Cuesta
carina. Yeah,
and you, I think
yeah.
getting simple cases, we would not have enjoyed actually.
No, no. But you have to be very carefully there. Yeah,
Yeah.
yeah, of course. You know. Sometimes you find this kind of lymph nodes subcarinally. That is like here. Yeah, yeah,
Yeah, correct, correct.
yeah.
I think, sir,
Yeah.
taking out completely is not a
Yeah,
criteria. So,
not
Yeah.
necessary.
you can just go with the
Marsupial
posterior capsule left
Yeah.
actually,
Yeah,
because
that
that
is
will be more, you can say, safe and
No, I do agree with you.
Yeah.
So I was thinking about, sometimes paratracheally or whatever, what it is.
Whatever it may be. I don't think there is need to go that below. But I think Sir
Beautiful.
reached the very correct plane. So
Yeah.
he's going to take it out complete only.
That's the best way, yeah.
Beautiful. Actually, taking out completely is more good because it will have less oozing. When you do a partial excision, the chances of oozing is more actually.
Yeah. No, that's true, That's true.
And it is a chain of lymph node actually,
Yeah.
not single. Because it is going high, so it's a chain of lymph node.
Yeah.
Hey.
I think you can cut off with a just a ligasior and finish it.
The other thing, something
Yeah.
that can look similar is a duplicate
Yeah.
an esophageal duplication cyst. Very
Another one there. Yeah.
If a duplicate cyst comes, we'll be happy, na?
Yeah.
If that comes, you are quite happy actually.
That's the happiness of the surgeon, eh?
Yeah, he's trying to do everything to complete.
Complete and perfect. Yeah.
Ready, sir? Now we'll mobilize easily that portion over.
Yeah, correct.
I was saying, no, just tried to mobilize, but feasible it come. Otherwise, I thought of leaving it behind only, but it came out well. It's okay.
Yeah. The node is at a different position, sir. You can take it out, that capsule. Otherwise, later on we will forget.
No.
Supposed to be most of the nodes here, and harmonic.
Yeah, just cut off and leave it.
Cut out, yeah. Yeah.
I think so people who send message not to this is not should not do it. I think they are very sensible people.
Sir, the node capsule is on the lung surface, I think, on the left side. The big one you took out.
This type of
just
cases.
Withdraw the camera.
See, this type of cases, we many series of cases have done.
Yeah. Any instrument will work in hands of sir actually. He's doing the dissection with the Maryland.
Stitched. Now you can see the regular in the groove. Very easily you can identify it. And umbilical tape, Kuduma.
So you are going for Ivor Lewis for this case?
Now what I always to take a 3 to 3 stitches like this for clearance of this one. If it intended.
Okay.
This is adenocarcinoma, and this node also I don't suspect it is a node. It is look like a cyst, infected cyst like. But biopsy we'll wait for this. And what is your opinion regarding the clearance of nodes along the left one? And this is a little advanced stage of the tumor. Now I'll be showing later.
This is adenocarcinoma, sir?
Yeah.
This is adeno. So this is the lymph node, sir, I was telling.
Yeah, that case I think, no, could stitch Kuduma? 20 and reducer. Yeah, 20.
You can take through that.
I think it will not come. I will put a bag and take it out.
Yeah, maybe later on.
Are you going to do a frozen section or whatever?
No, anyway, whatever that macroscopy available, we are going to take it. And anastomosis is going to be here.
Here,
And
there,
so that
yeah.
case, if I do frozen, it's not going to help me. Prognostic and the further treatment depends on that. Now
Yeah.
treatment
Abdominal
purpose
part,
it is
sir,
not.
has already finished actually.
Yeah, I have a adequate length of esophagus completely normal lower down, so no problem.
Okay.
And if it is not going to be this, I will consider it's only palliative, and the patient needs further treatment with a biopsy, everything, then we will look at.
So, sir, you always take this stitch to the esophagus?
No, if it is a lower esophagus, growth is not here, I will take a stitch and or umbilical tape, down. I think umbilical tape, I think is a technique other people can show,
Yeah.
And our two hand must be there to work on the left recurrential nerve.
Correct.
Then we can safely. Otherwise, injury of nerve, it is known. That's why I wanted to. I'll show them either this stitch here or a stitch to that umbilical tape posteriorly. We can bring it out to the intercostal space, lifts up. I'll show this is simple technique, and if only middle third growth, no, we should not do it.
Yeah. This is only for lower third.
I think 30 would have been better.
The needle is bigger, na? So
All against me today. Bipolar?
No, that's okay, sir. If once you put the knot, it will stay.
Yeah. Sometimes it bleeds more. I will bipolar control it, then I will take it a different stitch. See, you can see hematoma will form.
Correct.
Mm-hmm.
Umbilical tape. Umbilical tape. Bipolar.
So, Professor
You have to look for thoracic duct here. This is one of the good place to identify. It curves down, going here.
So you are, so your
this is a thoracic duct.
Yeah, that's the thoracic duct. Yeah.
Color is yellow.
Yeah. Mm-hmm.
Gas piece. Suction.
So your plan is to do the anastomosis at the level of the azygous vein, something like that.
I'm going to show stapling and here.
Yeah.
It's really heartening to see, even though we have reached 6 o'clock, there is more than 780 people on online viewing this live surgery.
Yeah, sir is there, so I think.
Good evening to all. This is Dr. Parsardi. I have this software version. Now I freeze the software video so that I can able to draw the line. So this is the trachea. So I'm drawing.
Very good. Very good.
Yeah.
You want to see the video?
Left bronchus, right bronchus. Sir, I freeze the video, sir.
He freezed and he's explaining the anatomy.
Okay.
That is the esophagus. Okay. So now I cleared it and then I released the freeze. Okay, you can see the.
So this you are doing where on the monitor?
No, I'm in GEM now.
No, on the monitor,
so
or
this is,
you are doing in the laptop?
no, I'm doing with my iPad.
iPad.
Yeah.
So that is what is getting
Yeah.
transmitted.
So it is like it is called a teleslator.
Close.
So I can for a teaching purpose, we developed this.
Yeah.
So
What is the name called as?
no, this is a teleslator, illustration. Illustration.
Illustration.
Illustration like a telemedicine is a teleslator.
Acha. Okay.
Illustrator. So teleslator. Yeah.
Okay.
That's excellent, Partha. I hope you will demonstrate it
Yeah,
next
last
time.
time.
Because
Last time what I have done
we are
without.
doing is taking images
Yeah.
and putting these lines ourselves, and we demonstrate to students. But this is
Any
actually
color
on
or
a,
anything we can make it.
Yeah.
Previously, what I did, without freeze, I made it. But most of the time, no surgeon moves. I'm not inside the OT. I'm outside.
I know.
Yeah, so I cannot instruct the surgeon. So no, he's moving. The field is moving. So that is it's not as much as what I explained. I'm putting. So now I can freeze it. Now I'm freezing it. I can unfreeze. So like that, we can better, explain to the audience during a live surgery.
Correct. I think since our training days at GEM, Parthasarathi was the most advanced in gadgets. So I think he continues to be same till now.
Something to be different, sir, always.
I know.
So what the quality you are seeing, like all the moderator, 8 to 10 moderator, what the quality you are seeing, the same quality, they are seeing in a Tleversity website. Yeah, all the audience, all the 780 audience are seeing the same quality.
Good evening.
So this is Tleversity. Is with some agency, or it is?
No, it is a new word by our the director, technical director, Mr. Venkateswaran sir. It is a University of Telemedicine.
Okay.
So that's
and
why
this
we
is
coined the name Tleversity.
Belongs to only GEM?
GEM, yeah.
Oh, that's beautiful.
Particularly the complex surgery like this and hernia surgeries. Any surgeries we can freeze and then we can show the structure.
Yeah.
Then we can.
And even I found in the Tleversity when in the morning I logged in, I think a lot of videos are there already.
Yeah, previous events video will be there.
A to Z is written. Whatever you want, you can type and search actually. That is beautiful.
இல்லாமா டூத்ராது போட்டு பிடிங்க இல்லைன்னா இது இல்லை அப்படியே வச்சுக்க இந்த சரி விட்டு இங்கே வா
Beautiful.
Bipolar.
That will do the job.
அப்படியே வச்சுக்கமா இங்க வா.
Here the challenge is with the cameraman. He has to be in line with sir.
So there is a question from the audience. So this patient is this patient required neck dissection?
Pardon?
is this patient required 3-field lymphadenectomy, sir? That is, a neck dissection is required for this patient.
This patient is we we will try. The gastric tube is not possible because it will not reach the neck.
See,
Another
I
question:
think
why not complete mediastinal dissection with the neck dissection and retrosternal gastric conduit?
I think there are two or three ways to answer it. First of all, if you are a believer in three-field nodal dissection, you have to do the neck dissection, and it depends on individual cases and the extent of the disease. Whenever we do neck anastomosis, whenever we plan McEvans or neck anastomosis, the three-field nodal dissection. If you are a believer, you do it. That is second thing. Second thing, retrosternal conduit is not done unless it's a palliative modality. Which is done where the esophagus cannot be resected. Sometimes in cases like stricture or corrosive poisonings, in such cases we plan retrosternal conduit. Otherwise, routinely, this is a mediastinal conduit is always done like this.
So this posterior is the shortest route, and some surgeon, once from Simon Law from Hong Kong, he's doing all cases. He's taking gastric conduit in a retrosternal way, substernal way. So it depends on the surgeon's choice. And if you have a total mediastinal lymphadenectomy, I think sir is completed total mediastinal lymphadenectomy. One is the standard, extended, and then total. If you do total, this is called functional mediastinal lymphadenectomy. I think that is enough. Is no need for neck dissection. We are not following the neck dissection in Gem Institute.
Partha?
Yes, sir.
Srijan here. One of the reasons why the substernal placement of the conduit is practiced because when there are a lot of incidents of gastric carcinoma, or some of the patients get esophageal carcinoma, and the conduit kept in the posterior mediastinum can develop gastric carcinoma. So in such patients, the dissection on the posterior side is going to be extremely difficult if we keep it in the posterior mediastinum. So if we keep the conduit in the substernal area, a second surgery or a sternotomy followed by a colon replacement becomes easy. That is the reason why some of the areas or some of the surgeons are keeping the conduit in the substernal route.
Yeah, it's nicely answered.
Yeah.
But what I find is that most of us land up in Ivor Lewis, and we don't practice the substernal way because that is our training maybe, and colon is we only take when there is a conduit failure.
Yeah, the other thing is in the other areas where incidence of gastric carcinoma is more, the chance of developing a second malignancy in the stomach, that is the conduit which is kept in the substernal area, if it develops, then it is easy to operate.
So must be in East somewhere, maybe in Korea
maybe
or
Asian,
China.
Korea, Japan, it is
China, they
because
practice because the incidence of stomach cancer is more.
yeah, the incidence of conduit cancer is high percentage.
Just one more. Sorry, just one more thing to add with regards to that question regarding the neck dissection. If it is a lower third or a Sievert's maybe 2 adenocarcinoma, a neck node will make it metastatic. Whereas if you get a squamous cell carcinoma mid-third, the neck is still regional. So basically, we talk about the neck dissection more in terms of squamous cell carcinoma, particularly in the middle and upper third. So in a lower third adenocarcinoma or in a Sievert's type 2 adenocarcinoma, perhaps the role is questionable.
No, I do agree with you. Any lymph node of the gastric cancer in the neck is a metastatic one, and this will be almost experimental surgery to do a lymphadenectomy of the neck in this case. I do agree with you.
Neck dissection will only be required maybe in very less cases where during the recurrent laryngeal node dissection, you find a suspicious node, then maybe on the side you see the node, same side neck you do. There is no point doing neck dissection on both sides because it has been not been seen to have cervical nodes in even in mid thoracic or uh, just near the carina tumors. But definitely the nodes along the recurrent laryngeal nerves are definitely needed to be cleared, which is almost reaching the neck actually. So you can tell it that it is 2.5, or it may not be completely 3 field, but it may be 2.7 or 2.9. But definitely, if you find a significant node along the recurrent laryngeal node, then definitely you need to do a cervical node
Section.
dissection on that side in the neck.
Bipolar. Sir.
One of the most interesting things is if you do an Ivor Lewis operation, how
Bipolar.
to do the lymphadenectomy of the supracarinal lymph nodes. Because we thought in the beginning that if you do this lymphadenectomy, the perfusion of the gas of the esophageal stump proximally will be impaired. And but nowadays we prefer to do the lymphadenectomy of both sides, even if you do Ivor Lewis anastomosis.
Correct.
And so you have to do that.
Section.
But in the neck, I don't think there is any indication for this. I don't know what to think about it.
No, that's very true. That's true. Now, just with just a comment, maybe from the panelists, if you can, with regards to the dissection where sir is doing there, mesoesophagus, and what is the correct plane, like to when we are dissecting? Any of the panelists want to take that?
So you see,
Bipolar.
mesoesophagus is
Bipolar.
something folding of the same paraesophageal fossa on the intersurface of the aorta, because you see it engulfs the esophagus, comes behind, then the both the layers they fuse, and then they become the para-aortic fossa. This is the way the mesentery is made. So this is what is the connection between aorta and the esophagus is the mesoesophagus, and by the side is the thoracic duct. So the plane of dissection should be exactly in the between the paraesophageal space and the para-aortic space, and whatever mesentery is there between aorta and the esophagus, it is both the layers is taken along. But at the same time,
Yeah.
the fossa from the para-aortic always go in the side to on the surface of the thoracic duct. So when it goes on the thoracic duct,
Go.
you should not keep that fossa intact so that your thoracic duct is projected,
Bipolar.
and
ಇಲ್ಲ 6
esophagus
மணிக்கு 6
only,
மணிக்கு
and the both the layers coming, which gets again separated to aorta. This everything comes out in toto. So when the specimen comes out, you will see there is a thin line on one side of the esophagus, which you can, if you put with the forceps, you can say that this is the mesorectal fascial
Mesoesophagus.
fusion, or
Yeah.
which is called as
Bipolar.
mesoesophagus. So everywhere we have found these mesentery of the is nothing but fusion of two layers of fossa, whether it is mesorectum, whether it is mesopancreas, or whether it is mesoesophagus. So this is important because all what is the content of mesoesophagus is nothing but the
Hello.
lymphatics.
This is
And
thoracic duct.
Yeah.
correct.
Hello.
Correct. Yeah.
Yes,
This
yes, sir.
this is thoracic duct.
Yeah.
I am going by side of the aorta now.
Yeah, correct.
Yeah.
So
Yeah.
this is where he's dissecting is just going just behind the fusion line. So the fusion line is taken onto the esophagus. So if you see the esophagus circumference is at a distance.
Look
He
at
is
you, look
taking
at
the
you,
fossa along with that. So that is what is called as mesoesophagus. And always it sometimes contains direct vessels from the aorta. So you have to do bipolar as is doing, the bipolar sir is doing. So once you do the bipolar, the direct vessels will be taken care. So that is how you proceed with the just from above down, and you reach till the diaphragm.
I do agree with you because that is the infracarinal mesoesophagus, from the aorta to the esophagus. And if you take all there are lymph nodes and there are vessels and some nerves. And if you take, and that is only, on this side. On the other side, there is no mesoesophagus. That is only there. Yeah. And you have to take out and to resect it in order to mobilize the esophagus completely. Yeah.
bipolar எடுத்துக்க.
Yeah. The lymph nodes there. Yeah.
Yeah.
This is subcarinal nodes. Huh?
Yeah. Yeah.
Sometimes you find, sir, just with the suction or with the bipolar, you can just delineate the, just anatomically say the anatomy of the trachea, the carina, and left and right bronchus for the benefit of the audience.
Yeah.
This subcarinal node, as Jagdish had told, that sir is dissecting from below, going up gradually, and there he will find the what is called as the direct branch on the midline, which is supplying these nodes. So you have to be, as I told you, always do this with a bipolar, so that you are totally having control to do the vessel coagulation with a bipolar.
Clean பண்ணுது.
So always when you do this, see below what structure is there, because the conduction of the whatever instrument you use should be controlled. Because you see, clear cut, you can see the tidal volume is very less. We keep it around 400. You can see that it is not an inflated trachea, but it is a flat trachea with the right bronchus and the left bronchus seen very easily. And you can see the way sir is moving to dissect the carinal nodes, subcarinal nodes, and you will find that these collapsed airway is the best way when you do this dissection, because if they are tense, the chances of having the injury is more. If they are collapsed with the low tidal volume, the chances of injury is less.
That's why that single lumen tube, endotracheal tube, and allows the membranous portion to collapse, both the trachea and the bronchus.
Because
and double balloon is not, that is not possible.
Yeah, in a double lumen, one of the bronchus will contain the end of the tube, so that will get inflated. Now you can see a completely collapsed trachea with the both left and right bronchus and the subcarinal part completely cleared.
There's a more natural dissection here in this way.
Bipolar
Yeah, definitely.
என்னமோ நல்ல அப்படி வச்சுட்டு.
I think beautiful dissection, both cervical, carinal, and paraesophageal.
left hand bipolar போடும்.
And meticulous hemostasis is being done because this area is quite vascular.
I'm using a bipolar in the left hand so that any bleeding I can control here.
Yeah, because he's using a suction on the right side and using a bipolar on the left side. And as I told you, sir is ambidextrous, so you can use both hands in equal speed.
Close camera, close. Okay.
I think beautiful.
Now, let the point of neck dissection you are all discussing. And nowadays the trend is we remove only the medial cervical group of nodes, and camera go to that level, and not the lateral group. And the lateral group morbidity more, and camera to that one, clean. So that medial cervical group of nodes, and better to remove through thoracoscopic approach, and need not go to neck and doing it. And I'll be this particular because of two big nodes, and I removed it and went to finish up because I'm anastomosis going to be here. So here, let us see, show the right recurrential now, deep cervical group, and the nose is, yeah, this is vagus now.
Yeah, correct.
And curve, left hand curved. இந்த இதில் நான் இதில் பண்ணிக்கிறேன், அதில் ஒரு இன்ஸ்ட்ருமெண்ட் போடும் போட்டு subclavian can be retracted like this, some instrument, it will be helpful. And initially I thought this fibrous band as a nerve, we left it out. This can be dissected out, and so we'll have a good exposure here. Go camera. And as Chris was telling, the nerve, yes, should not be handled as much as possible. Dissect the surrounding way and don't use monopolar cutting to the nerve. Harmonic. And bipolar maybe, but away from the nerve. And see, we'll try to see that. Okay. One instrument can be here. Close. Bipolar.
It's inflammation
Bipolar.
from that.
And the inferior thyroid artery can be seen from here up to that level. We'll can take it out the nodes.
Okay.
Yeah.
And I made the port for stapler, and so that's why that my two camera and this instrument hitching. Camera up. I can use one more 5M Pro port if it is hitching there. We'll be see. You can see the recurrential now going up.
Yeah.
Up,
I see
up
that.
camera. Right.
Yes, it is. Yeah.
Camera close to poke, close. And this.
That was going up.
Camera quick at the up, lift. Right. Camera இந்த பக்கம் திருப்பு. Get me one more 5 mm, sister. Hey, show me my needle. Okay. Holding. இல்லை இப்படி வச்சுக்கலாம். கவுடுமா. சிஸ்டம் ஒரு இங்கே சிஸ்டம் தாங்க இது பிடிக்குமா? இது இந்த பக்கம் வந்து பிடிக்கணும். இப்படி பிடிச்சிக்கோ. எஸ். ஏய் இப்படி தள்ளுன மாதிரி. லாங் இன்ஸ்ட்ருமெண்ட் இல்லையா? இங்கே கேமரா தூக்கு. இல்லைம்மா. ஹார்மோனி
It's beautifully demonstrated, sir.
I am dividing the peritoneum. It is slightly thickened. Close. Section, irrigation section கூட வேற நல்ல காஸ் பீஸ் எடுத்துங்க. ஏய் இப்படியே காமிச்சுடு. சக் இங்கே குடும்பம். இப்படி வச்சுக்கோ. இல்லைம்மா விட்டுருமா. அது விட்டுரு பரவாயில்ல. எடுத்துட்டு தூர. க்ளோஸ் அப். Bipolar. Close. Close, close. Harmonic.
Sir, it looks very deep, sir, almost apex root of neck.
Yeah.
So we can open the pleura a little bit. We can expose the right subclavian, sir.
Pardon, what is it? What you said?
Subclavian, if you open the pleura, so that the subclavian will be seen nicely. Still we are
Which
not.
pleura here? Nothing pleura, no. Here,
That
if
one,
you go,
right,
we will be
right
going
hand
to
you are
thyroid
taking.
only, no.
Yeah, that is. These are all node.
Yeah.
Yeah.
Oh, that vessel now, I think suction. That is artery. I just saw it, left it, and it become. So that is a fascia is the limit for which we beyond. It is a thyroid. We should not go.
Yeah.
And cranially we go to the identify the artery, then stop with that. That is better. இதில் வச்சுக்கணும். அப்படி வச்சுக்கோ. பைப்போலர். Harmonic. கொண்டாம கிட்ட நம்ம கொடுமா செக்ஷன் சார் சார் close.
I think this is okay,
Yeah.
Harmonic.
I think this can be taken, sir.
Yeah, we are moving.
Yeah, do you think so?
The keel down is also looks like a vessel, sir.
Pardon?
Below the node, below your curved instrument, that
Yeah,
vessel
yeah.
also can be taken, sir.
By reducer bulb or something? This that is sympathetic now.
Okay.
Yeah.
So this is the paratracheal area. The nodes cleared here.
Harmonic. I think this is reasonably okay. If I go too much there, also blood supply esophagus will be compromised. Harmonic எடுத்துங்க. இந்த பக்கம் அந்த பக்கம் up.
So here we have to be careful. This is the membranous trachea.
Yeah. And lifted up.
Could not touch here.
I dissected that side already.
Yes, sir.
Yeah.
So accidentally should not touch the.
Yeah, very important. Okay. எடுமா எடுத்துக்க. Lens clean. Head down, sister. Look at shoot. அதில் போட்டுருங்க. அதில் போட்டு ஹெட் டவுன் பண்ணுங்கம்மா. இங்கே இங்கே ஓடுங்க. இங்கே வச்சுக்கோ.
stomach tube is already in the thorax.
Yeah, I'll be pushing into the abdomen only. The
Yeah.
specimen will be taken that side. Huh?
Yeah, correct.
Sir. அம்மா இது ஒரு பேக் கொடுத்துறீங்களா? இல்லைன்னா இது போயிடும். பேக் எடுத்துங்க. இல்லை போடுங்க, அது முடிச்சிடலாம் கொண்டு. அது முடிச்சிடலாம் கொடுங்க. இல்லைம்மா Get a bag. Suck பண்ணுமா மாலதி? Suck. Ligature. Ligature கொடு.
So there is a question from the audience.
Yeah.
So what is more safer, near the nerve, harmonic or ligature?
Which one? For what?
Near the nerve, sir. Laryngeal, RL and left or right recurrent laryngeal nerve. Which energy device is better?
Any no energy source, all as far as possible, everything should avoid. Bipolar safer than monopolar. No monopolar near anyway, and sharp dissection closer to now it's ideal way. And bipolar ligature is okay because that age it does not carry the cartridge much. And the harmonic also carefully use it fine. Bipolar away from the nerve, seal and cut it. That is better. Any cartridge is not good for nerves.
Yeah.
Harmonic
ligature is better.
Yeah, it's better.
Lateral thermal spread is lesser than harmonic.
Yeah. Good.
But the main thing is we should not give traction on the nerves. That is the main thing.
Even handling itself is a danger.
Yes, sir. Yes, sir.
I think ideally cold cut and gauze piece is enough. I think we should avoid all types of electrosurgical equipment.
Correct. I think Jagdish told the right point. That cold cut with a cold seizure, and this is very important that no energy device near the recurrent. Even if you are using, keep a mind that the active blade should be away, but preferably should avoid.
Metal kudu.
But here the advantage of robotic surgery near the RLN dissection, it is so nice, and even a monopolar cartridge with the scissor, we can fraction of second we can apply, and we could see very close-up view, magnified. And for this lymph node dissection near the recurrent laryngeal nerve,
gas போகுது பாருங்க.
Really the robotic is advantage.
போடுங்க இதுல. உள்ள வீமா. அத போட்டு போய்மா ப்ளூ போடுங்கமா. இதில் என்ன குடும்பம் இதில் போட்டு கொடுமா எனக்கு, நீ அதில் செக்ஷன் போட்டுக்கலாம். ஏன் இங்கே வா. This is a crural, huh?
Yeah.
Diaphragmatic crural hiatus. Eh? Ready sir, put bound for sus. Stapler வாங்கிங்க. I don't know, gastric tube not seen, thus should not have slipped. இந்தமா எடுத்துக்க. வேற எது கொடுமா. Oh, this is a gastric tube.
Yeah. So this is the
It
gastric
looks
tube.
because I cut little longer, I can trim it here. Look husky. I thought it is a fundus of the specimen
No,
side.
no. That is the
yeah.
esophagus. This is
Okay,
completely normal.
Now, kudu stapler. Esophageal tube உள்ள இருக்க எடுத்துருங்க. இந்த டியூப் எடுங்க. ஓகே, ஸ்டேப்லர் கொடுமா. ப்ளூ கொடுங்க. என்ன
So you are going for a circular stapler?
No, a linear stapler.
Linear stapler.
Triple stapler, triple stapling. Yeah. This is I use a triple stapler, creating a wide stoma better. Harmonic kuduma.
Correct.
Just harmonic kudum. ரொக்காரலுமா வெளியில இல்ல.
See, again, this is one of the difficult step. The length is very short, no?
This one, no?
And that's why he did very nicely. Slowly he manipulated, and then he took that esophagus to the edge of the stapler. This is one of the difficult steps, because this side is aorta. This is the aortic area.
Yeah, because angulation and from the site of hinge to that is long,
Yes.
So you have to adjust at the tip of the stapler.
Yeah, you can see this is the aorta. This is the aorta, arch of aorta. So your stapler will touch that aortic area.
So we are taking out the stomach tube from the abdomen.
Let me see any attachment remaining. And
this is the left lung exposed.
Correct. Yeah. So through the hiatus, the lower part is pushed. Now
I have made a stitch and I have to remove it. And by chance, if it slips out, scissor.
Oh, there, yeah.
The specimen removed through pharyngeal incision. And after that, if it is hiatus, we are checking the hiatus. If it is hiatus required any stitch, we can make the stitch.
Yeah, that's okay.
Yeah.
Ball for sir. Here. Come this side.
Now the whole stomach has to come up so that it is a tension-free anastomosis.
அதை கட் பண்ணிட்டோம் இப்போ தானே பண்ணேன் அது இப்போ தானே கட் பண்ணேன் இந்த இருந்து தானே சொல்கிறேன் I took a stitch, no? Sister was very concerned whether I removed or not.
Because you see, it serves two purposes. One is that the whole conduit is going up, and the other is that the stitch is removed.
Another thing, it is for orientation of stomach tube also.
Yeah, very important.
Yeah,
very important.
The stitch is helping, so it's not twist.
Yeah, it is not twist.
If you see the staple line on your side, that is on the right side.
Yeah, this is the momentum, so it will come on the left side.
Staple line facing the camera. Is that right?
அதான் அங்க rotate staple ஆயிடுச்சுன்னு சொன்னேன். The way it looks like it will go to neck also.
Actually, we always fear when we divide.
This portion
the root of neck, sir. Yeah. Even if you do neck anastomosis, it will end here. It stays here only. Maybe
this portion I have to resect out because, and while stapling, I could see that greater short gastric vessels come this side, and if at all stapling, we can do it this side. You can color appreciate well, not this one. If you make it a stapler, blood supply will not go there. So now we have excess, and whatever the remaining, we'll see. And
Professor Palanivelu, which kind of anastomosis you are going to do the linear stapler or?
Is doing a linear stapling.
Yeah, linear. Side to side, then it will become another stapler. It will going to be roof-like,
Yeah, I understand what you mean because
I think the stapler's line should be posterior, na?
Yeah, I am going to make it this one.
Yeah, and
because the blood supply I am looking for, careful.
I think you have enough length.
I think
the extra part can be taken out actually.
And
that can be used to enter the enterotomy actually.
Perhaps you can resect, the top or not, or do you prefer to use? Because we do in this stage also the ICG in order to see which kind of the gastric tube is optimal, for the anastomosis.
Yeah.
I think your length is enough, is good.
Yeah.
இதுல
the
again இருக்கா? ஏமா
momentum do you feel should be on our side?
ஃப்ரீயா இருக்கா? டைட்டில் இருக்கா? டைட்டில் டைப் பண்ணிருக்குல்ல?
Oh,
சரி.
the
அப்ப அவங்க
momentum is on the good side now.
Because person is prone.
Yeah, the momentum is good. It's on the side of the aorta. Yeah.
Yeah.
But
ஹார்மோனிக் கூட
yeah.
நம்ம 20 எடுத்து பிடிஎஸ் எடுத்துக்கங்க. மொமெண்டம் அதான் அந்த இது அப்படியே விட்டுறலாம். நம்ம இந்த லைன்ல இங்கே ஸ்டேபிள் போட்டுக்கலாம்.
So always remember, momentum in a normal anatomy is towards the left. So
in prone position is on the side of the aorta. Yeah.
correct.
Yeah.
So because it is a prone position, it should be towards the aorta. That's all.
Yeah, yeah. And the stapler line looking to us. Yeah.
Stapler line looking to us. Correct.
Yeah.
கொடுமா சூச்சர் பைப்போலர் எடுங்க. கொஞ்சம் லென்த் எடுத்துக்கலாம். Okay.
The length is good.
கொடுங்கம்மா சூச்சர் கொடுங்க. என்ன கொடுங்க? ஹார்மோனிக் கொடு, பைப்போலர் கொடுங்க. Today gastric tip was not cut properly, and that's why I have to take it up.
Yeah. No, I do agree with you. I think just the top.
Top might need to be sacrificed actually.
Yeah, I think so. Yeah.
மறைச்சிக்கிட்டு கண்ணை மறைச்சிக்கிட்டு வச்சு up camera. இங்கே
There is no tension at all.
No tension.
No.
No tension. It is the stomach is so much relaxed.
Yeah, because he's already preparing to sacrifice also.
Sister.
Yeah.
All right. ஹார்மோனிக் இருக்குமா? சரி கூட ஸ்டிச் அது ஒன்று கொடுத்துரு ஒரு ஸ்டிச் போடு. ம். ம். வெளியில் இருக்கேன். அது ஓகே சிஸ்டர். மழை இங்கே வந்து இதில் பிடிச்சிக்குவான். நீரில் எடுத்துக்கலாம். இல்லை வேணும் அவர்கிட்ட பார்க்கலாம். ஹார்மோனிக் எடு. அப்படி வச்சுக்கோ. ஹார்மோனிக்.
So there is a question from the audience. What stapler do you use for stomach conduit?
Again, linear only.
Yeah, linear stomach creation of stomach conduit.
Conduit I created with initially with the golden cartridges. Then later I converted to blue.
Yeah,
as it goes towards the wonders.
Yes, sir. The first one will be golden yellow, and the subsequent will be the blue cartridge.
And with the Covidian, then you have to use green for the hand drum. Then finally you can change it.
Okay.
Kill mama. Kill. Right.
So what he told is the assistant to push the suture back so that he can do the enterotomy in front. So this is very important that your stay suture should be posterior.
It has gone cut.
That's okay, sir. If you put the
till stapler goes inside, the stay would have been better.
Better, but you will manage, I think, because that keeps the thing stretched actually.
சத்தமா கேளுங்க மேடம். கோவிடியன் கொடுங்க. stitch 60 இப்போ கொடு, அடுத்தது 45 கொடுக்கணும். நீங்களும் ஒன்று கொடுமா, உள்ள சுவிட்சர் உள்ள இருக்கு. க்ளோஸ்.
This is very important.
Mucosa is not cut actually.
Yeah, to fix the mucosa to the muscular wall. Yeah.
Already we're inside. So this is stitch is he's doing to fix the mucosa to the muscular wall, so that when you put the stapler,
ஒரு இன்ஸ்ட்ருமெண்ட் பிடிக்க முடியலையா?
That's very important. Yeah.
So that is a posterior stitch.
Yeah.
Which so there will no confusion when you push the stapler.
Yeah.
தள்ளி விடுங்க அப்படி. இப்படி பண்ண. அடுத்துற விட்டுரு. இதுதான் பண்ண சொல்லி. இப்படி பிடிக்குமா, இப்படி பிடி. இல்லை நீ இது பிடிச்சிக்குமா, இது பிடிக்குமா, இதை பிடிச்சிக்குமா, இதை என்கிட்ட கொடுத்துரு. அம்மா நீ ஏதாவது அங்கே பிடிக்கலாம. அப்படி வச்சுக்கோ. ஓகே சிசர். அம்மா பூஜி எடுத்துங்கம்மா, பூஜி போட சொல்லு. ஸ்டேப்லர் கொடு, ப்ளூ கொடுங்க. இல்லைம்மா இப்படி இப்படி பிடிச்சிக்கணும்.
So now
see the alignation is perfect actually.
Yeah. So now that the total,
இது வந்து மேல வச்சுக்கலாம். ஜான்சன் இருக்கமா, ஒன்னு கொடுங்க அதுக்கு. அடுத்து
total number of logins, that is the viewers, is 811 sir. Now it is 7 o'clock. 811 people is online now watching this video. Yeah. That is a login sir. Maybe some place it's more. Yeah.
More people.
Now what I'm going to do, I'm going to create a site to say anesthesia. Then and pyramidal type on a two stapler across. So it is tension free wide stone. இது அம்மா ட்ரோக்கர் இல்லைம்மா, ட்ரோக்கர் இல்லைங்க. எது என்ன சொன்னிச்சு அது இல்லை. அப்புறம் எது?
So this is the toughest part, to negotiate the stapler in a thoracic
இல்ல கொண்டா
Trocar.
கொடு கீழே இந்த பக்கம் பண்ணுமா?
That is also now it is close to
இல்ல
the.
இதுல போட்டுங்க, இதுல போடு.
The space is less comparatively.
Yeah, correct.
Yeah.
Sometimes we find difficulty in putting this trocar
Yeah,
through the trocar.
This is because that the trocar is this side. It is and now I'll show once staplet goes, then it becomes easier.
Yeah.
Still, I not opened widely.
Other point is you can put the trocar directly, sir. A stapler directly.
Yeah.
Without the trocar.
Usually directly will go, and if I should open
that
wide,
will actually use
bowl forceps
that will help. Very nice.
இங்க பாரு, கேமரா காட்டுங்க. என்னம்மா here our colleague suspects mucosa opened or not. கீழே பாரு. Okay.
No, when we took the stitch, I think at that time it was clear.
Oh, this side also I think I need to open. No, inge katte na bowl forceps kudinge.
It's there, sir. It's there. Don't worry.
One stitch anterior also place can lift up easily. And if we edge of this staple line easier, today I am using it differently. Suction.
Because you want to sacrifice that part.
Suction. Suck. இருப்பில்லம்மா, இந்த ஒரு ஸ்டேப்பிள் போட்டது பிறகு ஸ்டேப்பிள் அப்படியே உள்ள வச்சுக்கோ. ஓகே, ஸ்டேப்லர். ட்ரோக்கர் இழுத்துக்குங்க. இல்லம்மா, அது பிடிச்சிங்க அப்படியே. இதை பிடிக்கணும், சுவிட்சர் அந்த த்ரெட்டை பிடிச்சிங்க. ஓகே. இல்லம்மா,
I think we can introduce the esophagus side first, sir. The bigger one can be goes to the esophagus side.
இல்ல, பூஜி inside. பூஜி தள்ளுங்க. Some more. கொஞ்சம் மேல அப்படியே வச்சு. ஓகே, அப்படியே வெளிய இழுத்துமா.
Yeah, correct. So you can see the buji. So he confirmed that it is inside the esophagus, and that dilated the esophagus also. So that is how the presence of mind is to put put the bougie more.
Camera up, go up. Here, focus here.
So, what is the ideal anastomotic size? Is always around 3 centimeter is enough actually.
Little wide. Come back.
Little wide is better to avoid
This can be
stenosis.
length anyway. I am going to trim it. I can make it later.
Yeah,
But
because
still,
now this is a 60 stapler and it's firing till 5. So I think 5 is there. So 5
Camera, மேல போ.
centimeter. Ultimately, if you see inside, it will come to around 4 centimeter, which is
Yeah.
quite enough actually.
இல்ல slip ஆயிடுமா.
So this is a blue cartridge and
Suction.
so always immediately suction, because what you need to see is suture line bleeding inside. So always immediately suction.
Sutra, namaste.
Okay. Pardon?
Now the enterotomy will be closed. I think Dr. Palanivalu needs a big applaud after this anastomosis.
Stay. குடுமா
Everything is looks
மூணு
clean.
ஸ்டிச் வேணும் நீளமா வேணும் சின்னதாக குடும்பம் படுத்து எடுத்துக்கலாம்.
So if you see the anastomosis, it's just above the azagus. So that is why he had wide dissected the azagus, so that the anastomosis gets well placed at that site.
Section.
Dr. Palanivalu, I will be leaving because I have some work.
Okay.
So
thank you very much.
so
Today
much
you made
thank
it
you.
very lively. Very happy about it.
Yeah.
We'll
And
keep
thank
it
you very much for
yeah.
nice, clean surgery in such difficult cases.
Yeah.
Holding the nerves just like Sachin Tendulkar and doing everything like centuries and centuries to double centuries. So I think thank you very much.
Yeah. Thank you. We'll meet.
Yeah. Yes.
Professor Palanivelu, thank you very much for everything.
Okay, thank you, sir. I'll call you. I'll meet you then. Okay, thank you very much.
Bye bye.
Yeah,
Dr.
anybody
Rudra
wanted
here.
to continue, see, let them see. Otherwise,
let them
people can leave.
Thank you very much.
Yeah.
Thank you, Professor Gusta. Thank you.
Mohan Prasad. அது இழுத்துங்கம்மா அது இல்லைங்க இல்லை அது எடுத்துட்டு போதும் இழுத்துங்க அப்படி
So Dr. Inian Samarasam from Vellore and Dr. Sri Jayan is and
we are still here. Sir.
Yeah. Dr. Jagadishwar, Rosen, this all in the line, sir. Yeah.
என்ன டைம் என்னமாச்சு?
So now 7:20, sir.
Okay. BG, Sisson. मैं बीजी पास பண்ண போகல.
So this anastomosis, chief developed.
இல்ல இது இன்னைக்கு today it is not that proper.
Proper, yes.
And triple step anastomosis is very good, and even after this we can appreciate it.
Yeah.
And
so it will make fully mechanical. There is no need for suturing.
No.
The stapler entry will be closed with another two stapler firing. So it is like a T-shaped anastomosis basically.
Yeah, exactly same.
Yeah. And anastomotic, if you see, it's a very wide anastomosis, so the stricture formation is less. Leak rate is almost nil. Nowadays, our series leak rate is almost nil.
Last
with hands-on anastomosis, then I'm talking about neck anastomosis and interthoracic both. Then we went to semi-mechanical, firing one stapler linear cutter side to side, and then we sutured the stapler entry wound. That is also we are not happy. Then we started doing a circular anastomosis. Then we are doing this linear cutter with the 3 stapling T-shaped anastomosis.
Partha, are you talking about the neck anastomosis?
Yes, neck. Even now we are very happy with the neck anastomosis with this 3 stapling technique. Now for even in Ivor Lewis, for interthoracic, we are doing the same technique.
Okay, neck, are you using the circular?
Those days, sir, long back.
Yeah, okay.
Yeah.
Whatever it is, thoracoscopy has revolutionized the surgery on esophagus. The patient comfort and the surgeon comfort, everything is superb.
Yes, sir. Yeah.
I still remember the thoracotomies who are struggling to breathe and severe pain, and especially cutting the LD and a long incision starting from the posterior side to the anterior side, which causes a lot of problems to the patient. Postoperatively, it was a stress for the surgeon also. Patient won't breathe, breathing exercises, and lot of analgesics. All those were common at those times.
Bound forceps கொடுங்க. இனி எப்படி வச்சுக்குமா?
Even VATS also, the incision is bigger, sir.
Yeah.
VATS, from the beginning, chief, 96.
You can appreciate the bougie is going inside.
Yes, sir.
In this case, bougie is not necessary, but still we can be more confident. Now,
it's a wide anastomosis.
Yeah, it is very wide. No, it is going very smoothly. Very wide anastomosis. I think 37 French.
No, only ready, sir.
And this port, even if you make on chests 3 or 5, 4 or 5, the patient doesn't have any complaints of pain.
Yeah, that is true.
Once you remove the ICD, they'll show comfort. Yeah.
Especially the 5.5 mm port is too small. It's something like needle injury.
சரி, இதை முடிச்சுட்டு காமிக்கலாம். சரி, irrigation. 60 லோட் பண்ணிக்குமா உங்களுக்கு முதல்ல, இப்போ அப்புறம் 45 கொடுக்கலாம். இப்போ லோட் பண்ணி வச்சிருந்தீங்களா, அதே அப்படியே கொடுங்க சார். இங்கே சார். ஓகே. ஸ்டேப்லர் கூட
So there is the question from the audience, sir. Is stomach conduit look congested? Is it
that is by handling?
Okay.
And the blood supply will be good. And if you have ICG, you can check it by ICG. And huskiness because too much it we have handled, no? That's why.
So it is based on.
And if a doubt is there, try to cut this portion. See, now I'll show. Scissor kudungma.
and basically it is depends on the submucosal plexus of the
Caesar
vessel.
good. And if any doubt about the blood supply, you cut. This is a corner.
Yes,
This
sir.
going to
If the
come out.
corner
This
is
also going to
pressurized
come
good,
out.
yeah, that is going to come out actually.
Yeah. It will be nicely brisk bleeding. Usually it is okay.
Yes, sir. Yes.
Stapler good.
So the serosa is like congested. The mucosa.
No, it is congested. No doubt about it. இது பிடிச்சிங்கம்மா இதை பிடிக்கணுமா விட்டுருங்கிட்ட அது பிடிச்சிங்கம்மா கீழே வாங்க உள்ள வாங்க என்ன இங்க வாங்க எம்பக்கம் அப்படி மேலே தூக்கு தூக்கு இல்லைங்கம்மா அந்த பக்கம் இல்லை போச்சடா இல்லைம்மா முடிஞ்சிருச்சா என்ன ஒன்று எடுமா now you can appreciate here and if you want to access the huskiness all can be removed here you can appreciate it is a functionally end-to-end like see here and this is side to side tension tension free this is a stapler which is there so narrowing cannot happen
Yeah, that's true.
and same way up to inlet I can do it and kuduma இன்னொரு kuduma 45 இருந்த kudu sometime achalasia cardia huge dilated esophagus the same technique can be used and proximally can be trimmed
yes
like here
so there is another question from the audience sir
yeah please
are you doing a leak test for this patient
yeah if you can not only leak test if you can put an endoscope to look at inside how it looks like
since the bougie is there we can inject the air and then we can do leak test then is it do you going to do FJ for this patient we don't do FJ in our practice we are not doing FJ how do you choose the size of bougie
bougie take it out
no this is the bougie we are using for sleeve gastrectomy no the same size and FJ we are not no long back we stopped I don't think nowadays almost more than 10-15 years we are doing FJ some suspected cases we are doing a NJ
சரியா இல்லைம்மா இது எடுத்து
Yeah, Partha, FJ is useful when there is a complication. Otherwise, most of the
Yes.
time, I used to practice. I used to put FJ in all patients, but very rarely
எதுமா
there was some use on
Yes, sir.
this.
Yeah, we have selected case. We have we have done it. Now we stopped doing FJ, and some suspected cases. Second day we do endoscopy. We just check the mucosa of the gastric conduit.
Yeah.
There is no need for going inside the conduit. Only the anastomotic site level
Well,
is normal. Then is no need for any FJ.
Yeah.
பேக் எடுத்துங்கம்மா பிளாஸ்டிக் பேக்
Which
எடுத்துங்க
next another question is which port for lost stapler?
இது இந்த ஸ்பெஷல் போடணும் எடுத்துங்க.
Okay, I'll ask Chief sir what for which portion. I think all stapler is done with only sir stapler. Which port you use for a stapler entry, sir?
Both the stapler linear you can pass from lower one.
Yes, sir. Can you show it in laparoscopic camera, sir?
Pardon?
Laparoscopic camera, you can show the which port you use for a stapler entry.
Stapler is upper one, outside camera. And
difficult,
this instrument is a stapler.
The laparoscopic camera you can show the Proctor.
Yeah. Okay, take it up. Clean பண்ணிக்கோ. And we have a momental flap. We are going to cover the staple line.
That is another advantage of interthoracic. The view is good.
No, this was camera. This is stapler. And first stapler can go from here, but today I completely applied from here only. But linear side to side and across here.
This is the stapler entry. Where the stapler is. This is camera. This is working. This is working.
Cut it. This is a great momentum.
Yes, sir. We could see the even the pulsation of the vessels also. Mainly the arcade we should not handle. We have to edge of the momentum. We can take it, and then we can wrap it around the anastomosis. We can take pitch also. So the microscopic leak will be prevented by this, omentoplasty.
Come back. 20 எடுத்துக்குமா 4-5 பைட் எடுங்க. And I'm going to take it a few sutures so that great momentum not fall away from the staple line.
Post-op, do you routinely do a study, sir? Is that?
கவுடு போடுதுல இங்க இருக்கு
Paliveda, sir.
Now the viewer total viewers is 826, sir.
Now also
734 count is 826. It is increased.
But I'm sorry, that is not a straightforward case people to see. Trainers and practicing surgeon, okay. And I think sometime we'll show one straightforward case. I never expected both will go to this one. And
in the Vegas, we cannot predict, sir, which will be straightforward.
Both sides, the great momentum is coming.
Yes, sir.
Yes.
This great momentum is another way preventing a leak. It is also huskiness all. If a doubt is there, this is the best way. And staple line, if it is not, then you can overrun the suture. That is also feasible. This prone approach gives a wider view.
Question.
And even end-to-end suturing, initially as per surgery, we will be doing hand-sewn suturing also. That is all feasible. Lateral approach, that is not possible.
Sir, another
And the most
question from the audience. They want to see the ports and also the exact site, which costal margin each port.
Okay.
Usually we put 5, 7, 9.
Yeah.
At the end of the surgery, we'll show the port and then which
Yeah.
exact site also. Yeah. You can mention your name and which place. That is a very much appreciated. Question also welcome, and you can mention your name and place also along with the questions.
Get it? இல்ல இன்னும் வேற சூச்சர் கொடுமா இல்லை முடியாது கொடு இன்னும் சூச்சர் ஒன்று கொடு I think today's some of surgeons very good, observed so much. In this case, good indication to do surgery, something like that is true. In the beginning, as always, that's a way I have to look at. Safety more important. If this patient, if I can't operate and life, but many people think to advanced surgery not to be operated, and nowadays chemotherapy also works well, and the way it looks like, and results are very good. Not that everybody will have good result, but majority nowadays we found very good results. Better, that's why we attempt to doing it. And but of course, other risk factors all, and patients also should understand this. He's a poor guy and known cancer last 3 months, and not undergoing surgery because not affordable to go to private sector and waiting for. And then finally, my friend Mohan has referred this patient for today's surgery, and we are doing free of this patient. The other patient is he is affordable patient, and this is we are. Sir. And proline 10, proline, and hiatus must be narrowed. And see, you can see this, and the color of this momentum itself is so good color. This is the posterior side here. It will cover up nicely. What we'll do, I'll put a bag, and these two things I'll push into the abdomen, and the hiatal narrowing very important. That can be done either abdomen or here. I'll show you how it can be done here. Proline 10. Bag kuduma. These are two pieces will be missed out. We put a plastic and push into the abdomen, and they will take it later.
Sir, can you show the ports outside view?
Yeah. Take it up.
The exact site also you can tell, sir.
Generally, these are the ports we use it. It will be like this. Last case I shown, and it should have been here, slightly very close. That's why maneuverability today I'm finding difficult.
Okay.
And here, and there. This is my right hand. Now, today I didn't use much at all. This is a stapler passed through this one. Camera here. Generally, we work with the camera here. These two wheeled working. This is for attraction, other purpose we're doing it. But today, because all are closely placed up, we use the camera here most of the time.
Mostly it will be from 5, 7, 9, 11, 10.
Yeah. 3, 5, 7, 9.
Oh, 3, 5, 7, 9. Okay.
And the previous case, trocar placement very correctly came. That's why, in spite of such a difficult tumor, in working instrument angulation was so good.
So that the question was from Sri Lanka, sir. Dr. Aniston. He is asking about the port. And now another question Do you use ICG at all to check the vascularity? This
Yeah,
is Dr. Arnab Gupta, Kolkata.
I think you can explain that ICG will inject it to different ways.
Yeah.
One, if you want the thoracic duct to be seen, lymphatic, and injection to today we have done this both the cases.
Yes.
Some or other the machine did not work well. Some no, I am not able to show you.
Yeah, actually, in this case we injected ICG in inguinal node to check the vascularity. Sorry, thoracic duct. And so since this camera doesn't support for ICG today, so we are not showing that ICG. Otherwise, it will be helpful. And again, the vascularity checking with the ICG, that is not 100% proof. No, that time will be good, and sometimes
now if you use ICG, that huskiness or blood supply, you can find out very well.
Yes, sir. Yes.
Camera trocar pull outside.
One more piece.
No. Yeah, sisters and dog, everybody should keep counting. No pieces should be allowed inside. This is a stapler.
So there is a AI artificial intelligence software is there, sir. That is called Proximi. And if you install the software, that will tell you what are the things you left inside the cavity.
Versus. Cut.
But you are taking through the trocar, sir, or
I'll push it inside the abdomen.
Okay.
Anyway, specimen at that side, I'm going to do it.
Okay, sir. Okay.
Okay, Prolin.
So you'll be putting some sutures.
And we will try to attempt suturing here itself.
Okay.
Because most of the time abdominal finish, you don't go to the abdomen. This particular case, we'll be going for specimen. That time also we can close it.
Sure.
If you don't repair it and the herniation is possible, then the problem. And in fact, two of our cases after, one is 3 years later, one is 1.5 years after, came with a herniation to the chest.
Yeah, we've also had the problem.
This is a Prolin. You can appreciate the crural fibers. அம்மா தள்ளி கொடுங்கம்மா ஹெட் அப் பண்ணுங்க. Suction. Suction. Suck. Suck. Okay. Nail holder. Scissor cut ಕೊಡು. விட்டுருமா கொடு. அப்படி வச்சுக்க. எங்கம்மா அதுக்குள்ள come back.
So the closure of hiatus from thorax, it looks easier, sir. Even abdomen means the liver will be there, we have to retract. Here only the
No, this is better. No, anyway, wherever approach it can be done, but we have to do it. That is. Now it is okay. It's enough. Okay. Height is widened, then always better to suture. Now it's okay. Now we'll irrigate.
There is a question, sir, from Dr. KJ Singh, Delhi. Reason for narrowing hiatus?
Yeah.
So there is a question from Dr. KJ Singh, New Delhi. The reason for narrowing the hiatus. So most of the patient, if in a very wide hiatus, the colon, transverse colon might migrate inside the chest.
Yes. We have ourselves 2 cases we have done.
Yes. And then Dr. Kalpesh Jani from Baroda, do we need to take hitching stitch to hold the stomach up to the thorax? Here Jani is asking question whether the stomach tube to be fixed to the hiatus.
I'm going there to abdomen side. I'll see, then I'll fix it up.
Okay.
And anyway, the most important thing is gastric tube inside should not be too much redundant.
Yes,
push as much as possible, skip straight tension without tension, then it is better. Redundant at the hiatus will make a dysphagia or a gastric stasis in the tube.
There is another question, options if stomach tube is not looking healthy.
Yeah, already I told them, no?
No, another option, sir. Stomach, suppose you are not.
I have to trim further and make it up. Suppose if it is completely not able to anastomose, there is no length, then alternate this way we have to go for a colon conduit only. No, now we left out.
Yes, sir. And there is another question, sir. When do you start oral feeding? Dr. Arnab Gupta, Kolkata.
Yeah. That is, suppose you have done a gastric cancer and advanced cancer, both gastrectomy and esophageectomy, then case reconstruction is a colon.
Okay.
And right side colon and ileum, distal ileum is ideal one. And we can place it substernal or the same route we can make it.
Okay, sir. When do you start oral for this patient, sir? Another question.
Oral to, and tomorrow we'll be giving a Riles tube gastrographin study. If it passes duodenum free flow, then Riles tube feeding for 2 days. Fourth day we do endoscopy to look at the stoma side. Vascularity is okay, remove the Riles tube. Patient giving oral fluids and liquid, then soft, like by 6th day, the patient can go slowly for solid diet. But duodenal passage very important. If there is a duodenal holding, some patient gastric stage will be there. We should not give orally more. No, then it is problem. So we have to see. It is not leak test tomorrow. It is for the gastrographin study flowing beyond the duodenum. That is there. Riles tube feeding is tomorrow itself. Even eye fluids can be cut down by 24-48 hours.
Okay.
And then Riles tube feeding, and fourth ischemia, if it is there, it is always happen third, fourth day. The fourth day morning endoscopy, and no vascularity is good. Then Riles tube also removed, oral fluids you can given because already duodenum emptying. No, so the 4 days is a time for a crucial management of the patient. This is a protocol. Okay, okay. Thank you very much for all of you, and any questions put in the box. I will be sending you by mail. Thank you very much.
Thank you, sir. It is a very nice demonstration. Thank you. Thank you so much.
Before we wind up, I would like to make some announcements. Request Pashupati to put the slides, please. Yeah, the next month we will have Dr. William Chen from Taiwan demonstrating laparoscopic low anterior resection. That will be on 21st March, same India time of 15 hours. So request everybody to log in and enjoy the surgery and clear your doubts and any suggestions and everything. There will be moderators to help you out with your doubts. So this is one of the programs. Next slide, please.
This is going to be a live surgery from Chen, Taiwan. And same way, what the Palmelu sir video from GEM is transmitted, the same quality with the same different moderator, no, is 8 to 10 moderator around the world. The video from the Taiwan is going to be transmitted through the Tleversity site. So that technology we have. So not only from India, so anywhere in the world they can do live surgery that we can transmit it to the moderator and the delegates with the HD quality. Yeah. Okay, Roshan, you can continue for next.
Yeah. Next slide.
Next slide, another. There is no next slide.
I think you have only one slide. Anything is there?
I think about the Chennai hernia carnival. So
okay.
Anyway, it is next month between 15th and 17th at Chennai. So request everybody who are interested in hernia surgeries to join us. And there is also a MMAS program. So people interested can log in to the Amasi website and find out what are the registration fees and everything. So request all of you to go through it. And meanwhile, I would like to thank all the moderators for spending their valuable time. Professor Miguel Costa, Professor Prabal Negi, Dr. Rudra Acharya, Dr. Jagdishwar Gaud, Dr. Srijayan, and Dr. Mohan Prasad and Inian Samarasan. Thank you very much for being with us and making this program a success.
Yeah, thank you, Palmelu sir, and thank you, Roshan. Thank you, Partha. It was a treat to watch the mass doing the thoracoscopic diaphragm. Thank you very much. Bye-bye.
Thank you, sir. Thank you so much. Thank you, Roshan.
Okay. Thank you, Partha. Thank you.